The meeting will hold by the Vietnam Society of the Interventional Cardiologists in cooperation with the Thống Nhất Hospital, Ho Chi Minh City, and particularly to be cooperate with the US faculty. The topic today is small vessel, long diffuse lesion, and very tortuous, how we can do the optimal PCI. I think the topic is very interesting. As we know, the small vessel and long diffuse lesion really challenge for the interventional cardiologists. The outcome of the PCI is not good. In the short term, in the long term. In the short term, it easily induce the dissection or rupture. We must use a long stand, or sometimes we can print stand to the culprit lesion. And the long term, not good, very easy, recurrent myocardial infarction, ischemia, and sometimes, as we often stent failure, we must do repeat revascularization. So it really challenging for not only interventional cardiology, but also cardiac surgeon. And the tortuous, a very tortuous lesion in the same situation. And it may be a long, it often associated with the small vessel, the long diffuse or calcified lesion. Both of them belong to CHIP. So the cardiac interventionist should know how we can recognize this type of the lesion, and we can predict complication of obstacle or complication happen when we do a PCI to this lesion. And we want to know how to manage this type of lesion and how to manage complication happen when we do PCI. So this is the purpose of our meeting today. I think it's very interesting and very beneficial for interventional cardiologists. And by now, would like to introduce the panelists and faculty. I am Dr. Hồ Thường Dũng, the president of the Vietnam Society of Interventional Cardiology, Vice Director of Thống Nhất Hospital, and I am the co-chair with Dr. Thạch Nguyễn. He is the senior of every Vietnamese interventional cardiology. Dr. Thạch Nguyễn is the director of the Cardiovascular Research Laboratory and Methodist Hospital, Maryville, Indiana, America, academic dean of the Tân Trào University School of Medicine, Long An, Vietnam. And by now, I'd like to introduce the US faculty. We would like to welcome Dr. Faisal Latif, Interventional Cardiology, SSM Henderson Anthony Hospital, a clinical associate, a professor of medicine, University of Oklahoma School of Medicine, chair Sky Quality Improvement Committee, and immediately past president, Oklahoma chapter, American College of Cardiology, Oklahoma City, America. And the next, we welcome to the Dr. Michael Lee, Interventional Cardiology, UCLA Medical Center, Associate of Professor of Medicine, University of California of Los Angeles School of Medicine, Los Angeles, American. And the last but not least, Dr. Max Kanpur, Interventional Cardiology, Methodist Hospital, Maryville, Indiana, America. And we like to introduce about the faculty of the Vietnamese, Dr. Nguyễn Cửu Lợi, Vinmed Đà Nẵng Hospital, Đà Nẵng City, Vietnam. Dr. Đinh Đức Huy, Director of Cardiology, Interventional Cardiology, Tâm Đức Hospital, Ho Chi Minh City, Vietnam. Dr. Ngô Minh Hùng, Interventional Cardiology, Vice Director, Interventional Cardiology Department, Ho Chi Minh City, Vietnam. Dr. Hoàng Văn, Vice Director, Hà Nội Hospital, Hà Nội, Vietnam. And the last but not the least, Dr. Vũ Hồng Vũ, Director, the Interventional Cardiology Department, University of Pharmacy and Medicine, Ho Chi Minh City, Vietnam. Welcome all of you to today. And by now, it is your turn, Dr. Thạch Nguyễn, a brief introduction.
Thank you very much and good morning. I'm glad that the American team is here at the fourth session of the optimal PCI for small, long diffuse and tortuous lesions. Our team includes Dr. Faisal Latif, Dr. Michael Lee, Dr. Majid Tanbur, and myself. We are happy to collaborate with the best and brightest interventional cardiologists of Vietnam. At this present time, I would like to introduce Dr. Faisal Latif. Faisal is a friend of many years. I met him more than 15 years ago when we began to work with the ACC and SCAI. And at this present time, he is interventional cardiologist at the SSM Health St. Anthony Hospital, clinical associate professor of medicine at Oklahoma University School of Medicine. Faisal is chair of the SCAI Quality Improvement Committee and immediate past president of the Oklahoma chapter of the American College of Cardiology. Today, Faisal, he will talk about at the beginning, strategies in optimal PCI for small, long diffuse or tortuous lesions. Faisal, it's your time.
Thank you very much, Dr. Nguyen. I hope everyone can hear me.
We can hear clearly.
Okay.
See
I'm in Oklahoma City. You guys may have heard that we get tornadoes here, and we have a tornado weather right now. So that's why maybe my reception may not be great, but I hope that in the next 15 minutes or so, I will discuss some basics of strategies in optimal PCI for small, long, diffuse, or tortuous lesions. I have started sharing my screen, and I'll go to a slideshow. So thank you very much for the kind introduction, Dr. Nguyen and Dr. Dung. So it's my pleasure to be here. I've been in Vietnam a couple of times, and it's a true pleasure to be back in company of friends. So thank you for having me. Here are my disclosures. So I'm going to start with a so as you can see that in this angiogram, the major coronary arteries are quite normal, but this OM2 has a hairpin turn, a very tight lesion, and just TIMI1 flow. So I just wanted to set the stage with this angiogram, and I'll come back to this case a little later. So generally speaking, small vessels are defined by coronary arteries that are less than 2.5 millimeters in diameter. And I put over here by intravascular ultrasound, because many times when we do an angiography and size the stents or think of the vessel size based on angiography only, we can be mistaken. We do procedures on chronic total occlusion. Sometimes they look like that this is just like a 2.5 millimeter blood vessel or 2.25 millimeter blood vessel, but when you balloon it and then do an intravascular ultrasound, it turned out to be a 4.0 millimeter blood vessel. So you just have to be careful to size the arteries based on intravascular ultrasound. Small vessels have a high restenosis rates, even with drug-eluting stents. Delivery of stents could be difficult, as most of you may have already experienced. Complications are more common, dissections are more common, especially the dissections can become spiral dissections, particularly when in the circumflex artery. And when you are encountered with small vessels, always weigh the risk and benefit of performing PCI. It is not always necessary to fix small blood vessels because, you know, medical treatment is quite good these days. Outcomes are quite good. So you can choose to treat with medical therapy in a given patient. So always take the patient into consideration, not just the angiogram in consideration when you're making decisions about proceeding with difficult PCI in small and tortuous vessels, particularly if the lesion is very long. Tortuosity, if that is combined with small vessels or even independent of small vessels, sometimes in large vessels, wiring can be very challenging. Just put a wire down is going to be, can be very difficult. Then delivery of equipment is challenging. And there is increased risk of complications in those blood vessels. There are some key principles when considering PCI in small and tortuous vessels, or even for tortuosity. I would also say that even if you're fixing a big vessel, then there are some key principles to keep in mind. One is to get strong support, and I'll elaborate each of these points a little bit more in detail. You have to have the appropriate guide, use of guide extensions, choosing your wires very carefully. The wire technology has come a long way in the last few years, courtesy of particularly Asahi from Japan, that we have a lot of variety of wires available. Using a microcatheter can be very handy in this kind of situation. Lesion preparation is very important in order to be able to deliver stents to these lesions. So how do you increase support? Increasing support, the first thing is choose a longer sheet. Generally speaking, when I am doing a case where it's challenging to wire, I usually choose a long sheet, at least a 25 centimeter sheet instead of 10 centimeter sheets. So 25 centimeter or 45 centimeter sheet if you're coming from femoral approach. Now, if you're coming from radial approach, then long sheet may not be very helpful, but sometimes it can be, depending on if you are encountering problems in the arm or not. The other thing is to use 7 or 8 French guide. If you're coming from radial, you can use a 7 French guide, either sheathless, or there is a 6 and 7 slender sheet, like a Terumo sheet, that can be very handy. Supportive guide catheters. So if you're in the left system, use of extra backup, EBU or XB guides is much better than using Judkins guides. For right coronary artery, I would choose something like an Amplatz left guide instead of just a JR4 catheter. Use of buddy wires can be very useful. Then sometimes using stiff wires when you're trying to deliver balloons and stents can be very useful, particularly if you have a microcatheter in the artery already, so you can use it to exchange out your first wire. Wiggle wire comes in some wiggles and can get you off of the calcium and the tortuosity to some extent and be able to deliver stents. Now, guide extension, I'm pretty sure you guys already use, things like GuideLiner, GuideZilla. Using an anchoring balloon can actually be very useful, particularly in a right coronary artery. If you cannot use a very supportive guide, if you're using a JR4 guide, for example, and you have a conus branch or an AV nodal branch, you can wire that branch, put a 1.5 millimeter balloon and inflate it at low pressure, maybe like 6 atmospheres. And then you can put a wire down the coronary artery and might be more successful in increasing the support with the help of an anchoring balloon. Microcatheters help a lot. These days, the microcatheters that have been developed with an intention of treating chronic total occlusions, getting through septal branches, retrograde, antegrade, these microcatheters like Turnpike LP, Caravel, Fine Cross, Corsair. I missed the name of Corsair. Corsair is a great one. So these microcatheters can actually be very handy because except Caravel and Fine Cross, the Turnpike and Corsair, you can actually spin those, and they can actually may be able to negotiate many tortuous arteries. And the profile is very small, particularly Caravel is very small. I've found it to be very useful, particularly in retrograde CTO PCI, that actually it can go across septals, which are very small. Choosing a wire is, I think, the most number one important factor in doing PCI, particularly when in doing difficult PCI, and even more so when you're doing PCI in small vessels or tortuous vessels. So knowing your wires can be very helpful. So I've divided the wires here in two broad categories: the non-polymer jacketed wires and polymer jacketed wires. The non-polymer jacketed wires, there are composite core wires like Xion, SU03. Then there is a dual coil wire like the Samurai wire. Then the polymer jacketed wires such as Fielder FC, Xion Black, Whisper wire is one of my favorite wires. I've been using it for a long time. It's a hydrophilic polymer jacketed wire, but it's very benign in my experience compared to some other polymer jacketed wires because it causes less dissections or less distal wire perforation compared to some other wires, because you have to be very careful when you use a polymer jacketed wire because it can cause a distal wire perforation. Pilot 50, Pilot 200, particularly in CTOs, can be very handy. Another wire is Fielder XT. Fielder XT is an 009 tip wire, so and can go through micro channels and can slip through them very efficiently. PT2 is an older wire and can come in very handy if that's what you have access to. Xion Black, I particularly wanted to talk about a couple of wires because Xion Black is one of them, and I have come to like this wire very much lately. I've used a lot of CTO wires, a lot of soft wires, and a different variety of wires over the years. But this wire, I think, is a significant advancement in wire technology. It uses it's from Asahi, Japan. It uses Act 1 construction for torque response and increased support. It is polymer jacketed. It has a high tip flexibility. And just 2 days ago, I had a case in a retrograde CTO PCI where the wire not only went through the septal, actually it was able to penetrate the proximal cap and actually went all the way to the anti-grade guide. So it is such a great wire that I have really come to like this wire very much. It's not a heavy wire. It's only 0.8 gram tip force, but it's very flexible, very torque responsive. So I like this wire very much lately for this kind of tortuous lesions. Another wire that I wanted to discuss here is SU03 wire. This is a very, very soft wire. So almost if you cannot shape this wire. This is so soft, it's like a thread. If you try to shape it, it won't take any shape. It's such a soft wire, but it can negotiate very tortuous vessels. It basically was designed for epicardial collaterals for a CTO PCI, and it can negotiate very tortuous. At the same time, even when you are doing a normal PCI in a tortuous vessel, small vessel, this has a very small profile and actually can cross the lesions very well, in my opinion. Next is wiring technique. Many times the wiring of coronary arteries in experienced hands can be very easy. You can just take a wire, not use any torque device, and you can just manipulate it with your fingers and it will go down. But when you are doing a small vessel, tortuous vessel, you have to be very careful in wiring because your first chance is your best chance. So you have to, in my opinion, use a torque device attached to the wire. Just control your torque one-to-one, very deliberate, very intentional. Don't let your wire slip outside of your control. So I think wiring technique can be critical in small vessels and tortuous vessels. Delivering stents can be very challenging, but the critical part is the first thing is lesion preparation. The lesion should be adequately dilated. If you think there is not much calcium, then use a regular balloon, upsize the balloon slowly. If you can advance an intravascular ultrasound, then advance that. And based on the findings from IVUS, you can see if you need a cutting balloon or angiosculpt balloon, like a scoring balloon. So adequate lesion preparation is critical. Now, if the vessel is very small and you cannot deliver even a 1.2 balloon, a sapphire balloon is available these days, which is a 1.0 millimeter balloon. And I think there is another counterpart from Japan that is a 1.0 millimeter balloon that might cross where other balloons would not. Now, you have to be careful if the lesion is very calcified. Of course, if it's a very small vessel, you would not use atherectomy. But if the vessel is 2.5 millimeter diameter or above and it's calcified, then atherectomy can be used in tortuous vessels. But you have to be very careful in using that. Generally, if it's a tortuous vessel, I try to avoid orbital atherectomy, but rotational atherectomy can work quite well and is fairly safe. But if the tortuosity is excessive, then it's not safe. On the other hand, laser could be safe because you're not rotating a device at a very high RPM, and could be safer if the blood vessel is very tortuous and you need a debulking device to prepare the lesion for delivery of stents. Now, if the stent delivery is difficult, if the lesion is long, you can try to deliver a shorter stent. And a shorter stents can actually deliver better than medium length or long length stent. You may have to use multiple stents, but that could be one technique of delivering stents. Thin strut stents these days are on the market, and these stents may deliver better as well. You can lubricate the stent with a rotaglide or a Viper slide outside the body and then try to deliver it, and it might deliver with that technique sometimes as well. Another thing that I don't have on my slide is a wiggle wire. So if you have a wire down and you cannot deliver a stent, but you can exchange your wire out to a wiggle wire with the help of a microcatheter, then you can actually use the wiggles of the wire back, and you do this to and fro motion on the wire, and that might get the stent off of the calcium and can negotiate the tortuosity, and you might be able to deliver a stent with that technique. So with that, I will start talking about a case. So the case is that of a 77-year-old female. She's very healthy, no significant past medical history. She's a thin, retired air hostess, does not take any medications, does not have high blood pressure or diabetes. She takes some herbal medicines, but no real allopathic medicines. She was admitted with chest pain. There were no EKG changes. Her troponin peaked at 0.5 and then started coming down. So we chose to do a coronary CT angiography. We did not do an invasive angiogram. She's a thin lady, and the coronary CT angiography was normal. The report was normal. I looked at the images; they were fine. I did not see anything abnormal. Even a radiologist read it. There was no abnormality. The chest pain resolved. The patient was discharged on aspirin, clopidogrel, and statin to pursue medical therapy, which was the preference of the patient as well. However, just 2 days later, she came back to the emergency room because she started having severe chest pain again. This time her troponin went up to 13, much more remarkable than the initial one. So we did a coronary angiography. And here is the angiogram that I showed initially. And so this was the OM that was totally missed by CT angiography. It did not see this lesion at all. The rest of the coronary arteries, the LAD, you can see the circumflex, the PL branch, the RCA, they were all totally normal. So the CT just missed this focal lesion in a very tortuous OM2 branch. A extra backup 3.5 guide. This is from radial approach. And then we put in first just started with a whisper wire, and was hardly able to get into that. You can see that there is first tortuosity here, second here, third. So there are 3 bends already before even getting to the OM. I was hardly able to get the whisper wire down to here, and it would not make that hairpin turn at all. So then I used a microcatheter, which was a Corsair, and changed it out to a Fielder XT. The Fielder XT made the turn, but would not follow into the lesion after all these turns. So then I changed it to a Xion black. And also I had to put in a support wire, buddy wire down the circ. And this is a Suzuki catheter, which is like a twin pass catheter. So it has two lumens. One is an RX lumen where this Fielder XT was sitting, and then the Xion black is here. And then, after very careful manipulation and torquing, we were able to get a wire down all the way into the vessel. But as you can see that once the wire is down, even Xion black is a very soft wire, the whole artery is now clamped down because of the pseudo lesions. It's even hard to tell where the original stenosis was. So you kind of have to remember where the lesion was. So the lesion, as you can sort of see, starts here and then finishes here, but there is just no flow after that to be able to see where the finishing part of the lesion is. So I used a 2.0 by 12 millimeter regular balloon to perform angioplasty here at just 8 atmospheres. Actually, I wanted to be very careful because you never know how this vessel is going to respond. And after that, this is the vessel opened up. This is after a lot of nitro and after balloon that you can see that the lesion looks better. And then we were able to deliver a 2.25 by 18 millimeter drug-eluting stent. The vessel is so small that I could not advance an intravascular ultrasound in it. It would not be very safe to do so. So we delivered this stent, and you can see that the flow is much better, even though there are pseudo lesions. So you cannot be sure whether the vessel is completely treated or not. So then I pulled the wire back to the soft part, and then it looks much better. And you can see that the distal vessel is okay. This is the first time I could see it because I could not tell, if there could be a distal perforation, a spiral dissection, all of those things that can happen in such arteries. There is still a pseudo lesion in the proximal vessel, so you have to be careful not to put a stent in there because it is just from the wire. Even though it's a soft wire, Xion black, it still causes the pseudo lesions to persist. So then I pull the wire back, and you can see the pseudo lesion is gone and the vessel takes back its shape of the hairpin. And this is another view, areocaudal view, in which you can see that the lesion is completely treated, and we have a nice result with the TIMI-3 flow, no distal complications. So in summary, when encountered with this kind of small tortuous vessels and diffusely diseased vessels, first of all, pay attention to strong support, good long sheath, larger sheath if at all possible, 7 or 8 French, and use the appropriate guide. Use a microcatheter whenever you wire. Even if it looks like the wire may go easily, you never want to regret not using a microcatheter, because then you will have to lose wire position if you're using a short wire and you don't have a microcatheter, because having a microcatheter gives you the liberty of changing out the wire and stuff like that. And then choosing your wire carefully. I think this is the most important factor in treating these lesions. And then adequate lesion preparation before delivery of stent can make the case go easier than with good preparation. That's all that I have. Thank you very much for your attention, and I'm happy to take any questions or any further discussion. Thank you so much.
Yes, thank you very much for the very excellent presentation. So now, any opinion from the faculty about the presentation of Dr. Faisal?
Dr. Lloyd.
Yes, thank you, Professor Faisal Latif, for your presentation. It's very educative about the tip, tricks, and principles for PCI, the small and tortuous vessels, and especially in your practical case with an OM long stenosis. In this case, do you have any opinion about the drug coating balloon for this case?
I think drug-coated balloon is a good idea. We don't have it in the US. They are not approved. So, but I think drug-coated balloon is a good idea, especially, for a patient who doesn't want to take medicines. As you remember, I mentioned that, she takes herbal medicines and she's not very convinced about allopathic medicine. So I think drug-coated balloon is definitely a very good idea. If you have an adequate size balloon and you get a very good result with that, then I think that would be very reasonable for this small vessel.
Thank you.
I have a question for you, Dr. Faisal Latif. Do you concentrate on the length of the balloon when you deal with the tortuous vessel or tortuous lesion? So, for example, 10 millimeter or even 8 millimeter compared with 15 or 20 millimeter. What do you think about this?
Yes, I do think about that. I try to use a shorter balloon because I think the delivery of those balloons is easier. And you can do multiple inflations if you have to, even though I try to avoid multiple inflations in coronary arteries, because I think when you inflate multiple times, there is a higher chance of dissection. So, so you have to be careful. But I think if you have delivery issues, then using a short balloon is a good idea. One thing that I always keep in mind, you never know that after ballooning, if you will be able to deliver a stent. So you have to be careful in ballooning. Yes, low pressure balloon, because you may have to leave it at balloon. You may not be able to deliver a stent. So always keep that possibility in mind. It's particularly the case that I showed. Now, if your vessel is big, then of course, you have to be aggressive and use a balloon and dilate it adequately. But in a small vessel, always think that you may not be able to deliver a stent, and therefore, just balloon carefully.
Thank you very much, Dr. Latif. So I have another question that in the meantime, I'm waiting for another question. So I have another question that do you usually make the curvature of the stent when you deal with the tortuous lesion, like you make a bend on the stent? So do you usually do the technique, or you just keep the original curvature of the stent? Thank you.
I have never shaped a stent outside the body. I've never bent a stent or anything like that. This is a technique that has been described. So it may have worked for folks. I honestly have never done it, so I cannot give you an opinion about that.
Yeah, thank you.
Sorry, I have a question for Dr. Faisal Latif. Yeah, when we're very tortuous, when we use rewrite, may usually make procedural lesions. And how to know is that is procedural lesion and the true lesions, please.
Sorry, maybe my connection is not good. Your question cut out a little bit. I think you were asking about pseudo lesions, and could you repeat the question? Because I'm not sure if I heard it right. Maybe my connection is not good.
Yeah, I mean
lumen, true lumen and four lumen, four channel.
No. I mean that when we write the tortuous lesions on the way to make postural lesion. Yeah, postural lesion. So I want to know how your experience, how to know it's true lesion or postural lesion after we write the lesion.
I think your diagnostic angiogram is the key. You have to know from your diagnostic angiogram where was the lesion. You have to remember it, you have to know it, and you cannot, because once the wire is in, it's very hard to tell that where the lesion is and where the pseudo lesion is. But whenever a wire goes into these tortuous arteries, they're almost always going to develop pseudo lesions. So, I think that's the only way to know from the diagnostic angiogram. You have to trust your diagnostic angiogram.
Yeah. Yes. Thank you. Yeah.
So, any question from the chairperson and the faculty?
Yes. Thank you for Dr. Fastif for very elegant presentation. So. As you mentioned in the your presentation about the the IVUS imaging when we do the PCI with the small vessel and diffuse vessel. So with the small vessel, which criteria for the optimal result with the small vessel? Do you have any comment about the optimal result with the IVUS in small vessel stenting or balloon? Thank you.
I think, if you can get an IVUS down in a small vessel, as long as you have good, do it before and after, as long as you have good stent expansion and stent apposition, that's sufficient. Because yes, I mean, when we are treating a large vessel, we want to get a minimal stent area of at least 7 millimeters squared. But in a small vessel, I am not aware of any particular criteria that you want to achieve in a small vessel. So as long as your stent is well expanded and apposed, I think that's all what you wish for. And then you have to be careful, because if you try to dilate it too much, it could be risky in a small vessel. So that's what I would do with an IVUS. I use IVUS about 90% plus times in my PCIs these days. So
yeah, thank you.
Please, Dr. Nguyễn Cửu Lợi.
Yeah, I have another question for Professor Latif. Maybe come back to the indication for PCI, the small vessels. There isn't any definition for small vessel so far, 2.5 or 2.75, for example. So the indication for revascularizations, I think we should base on the diameters of the vessels and the downstream length and the myocardial perfusion amount. So do you have any criteria for indication of PCI for the small vessels, especially the side branch like OM or diagonal?
So in all probability, if small vessels, I'm not a big fan of doing a stent in small vessels. Like the case I showed, if this was a patient with stable angina or something like that, I probably would leave it alone. This patient of 13, that's why I went after it. But otherwise, it's medical therapy is actually not a bad idea. In this kind of patient, 77-year-old, there is one vessel that's diseased and rest of the coronaries are normal. I think medical therapy is a very good idea. So, but if it's a 55-year-old, patient that's having a lot of angina, then you have to treat it. But yes, if you have to use a very long stent in a small vessel, we know that the outcomes are not good. The restenosis rate is very high. Many times I've treated, restenosis, and you can do whatever you want. You can use laser, you can use, IVUS, you can get beautiful results. They're back in 6 months. So I think it's a losing game when the stent length is long. And, in my opinion, if the stent length that you have to use is longer than 23, then, you have to think about it carefully, whether you want to put a long stent in a 225 vessel or not.
Thank you.
So Dr. Latif, I think you still have short time to ask you another question before we go to the next presentation. That you just mentioned about the IVUS in the tortuous vessel or tortuous lesion. So how do you stay away from the pseudo lesion when you do the IVUS at this segment, because the IVUS catheter usually make the vessel strength better than before that. So how do we escape from that? Thank you very much.
So the case that I showed, I could not even get an intravascular. I did not even, try. I tried a little bit, but it was a small vessel. I did not even try it because it would not go. It just as simple as that. But if it's a larger vessel, like a big right coronary artery that's, very tortuous, then I think after adequate lesion preparation, you will be able to get an intravascular ultrasound down. And then, I think you can use those criteria. So I think otherwise, and even if there is pseudo lesions, then I think, still you can get a pretty good idea about the plaque, the pseudo lesion. I think you can get an IVUS through a pseudo lesion, okay. But if you can't, you can't, you should never force it. But otherwise, if you can get it through, actually you can optimize your PCI very well if the IVUS can go down into a larger vessel.
Yes, thank you very much for the presentation and for answering our questions. So I think it's time to go to the next presentation. So I would like to introduce Professor Ho Tương Dũng that will talk about the PCI of small, long, diffuse, or tortuous lesion. How could we do that? Thank you very much.
Okay, thank you for introduction from Dr. Hùng. Let me share my presentation. My presentation is not a lecture. It's a serial case report, and I hope I give some clinical case for demonstration and for your discussion. Maybe 4 or 5 cases. The case number 1, small diffuse disease, left main bifurcation, non-STEMI. The patient is very young, 43-year-old. He is the relative of our colleague, our doctor. He suddenly checked band and hospitalized, were diagnosed acute MI with a non-STEMI. And this is the coronary angiogram. As you see, the distal left main disease involved to pull the ostium of the LAD and such, and the long diffuse lesion along the LAD and circumflex. When we saw coronary angiogram, I don't know how to do, so I refer the patient to the cardiac surgeon. But the cardiac surgeon refused at the first sight when they see the coronary angiogram, because they thought the vessel is very small and no location, no position for the bypass trap insert. And his family, my colleague, bring him to us again and to talk me to do something. And so what can we do and how can we do? We try to do something. We have a plan to do 2 bifurcation. The first, of course, the distal bifurcation of the distal ligament with the ostium of LD and circumflex. And the second, I think the diagonal might be rather big, so we try to keep the diagonal. So we do the technique to bifurcation to 2 position. You can see here, and in this picture, we already perform 2 stand in 1 stand with when we do the estimation, because we don't have exactly diameter. We have the intravascular image OCT. But the OCT in this case cannot help give me more information, because as you know, the OCT to record the clear image, we must flush blood out of the vessel. And if the vessel is very small, the catheter OCT inside, we cannot flush the blood out of, so they cannot record the image. So we do the estimation, not exactly, but maybe in the mid LD 2.5, and in the diagonal 2.5, and in the mid LD maybe the 2.75. And we go to the distal left main, and in this position we have one question: we keep the circumflex or not circumflex? How to keep? I think if we deploy stand in the distal bifurcation, the cert maybe go away. So and how much, how diameter, and in this situation and in that time I have no experience. We use the small stand 2.25 millimeter to keep the ostium of the cert, and the stand up from the left main to LD proximal segment 3. And we do the final kissing balloon. And I think the last result look okay. And we don't record the OCT before we do PCI, but we have a record the OCT after, and 1 year after that. But yesterday I looked for the OCT file, but no, I don't find. But yes, so I think that this is the last result, and with the result of the PCI, I think the cert may be bigger. But in that time, when I do in a immense situation, I don't know how much the diameter, so we must try a small stand to keep patent. So maybe 3 pause and pause 1 year. And in I don't have experience about to do the same situation in the last time, but by now I have maybe some experience. So in this case, I have one question for the expert, for the faculty, and for the panelists. In the long diffuse reason, such as this case, we have the strategy, no stand strategy or standless strategy. And in this case, with the position in the left main, distal left main, and in the setting acute coronary syndrome, can we use no stand strategy or standless strategy? I feel I'm not confident to use the no stand strategy in this situation. Okay, the second case. The second case, one case with calcified tortuous small diffuse lesion. As you see in the right coronary artery, a very tortuous, calcified, and small diffuse lesion. And in the right, the same tortuous, calcified along the LED. What we can do? Of course, in the normal situation, we don't touch about the RCA because it's very tortuous, very small, very calcified, long lesion, and maybe not good to touch, maybe more complication. But in this case, we have planned to do the PCI to the left coronary artery. So we try to do something in the right for which the hope maybe can supply some blood flow to the left. For when we do the left, it's more safer. Wiring and PCI is surely pre-dilatation with a small balloon. And we made decision to stand in only proximal and mid of the RCA. Because in the distal of the distal RCA is very tortuous. When we do pre-dilatation with balloon or stenting, very easy rupture. So we choose stenting only a proximal segment and a mid segment. I don't know after we do stenting for the right coronary artery, how much it can increase blood flow to the left. I don't know, but it made me feel more confident go to the left. About the left, because it's very tortuous due to the calcification, so it must attract me. Wiring, and we do atherectomy. Can you see very tortuous, very calcified tortuous? Then we deliver the stent with the help of Gidagella. You can see Gidagella. Okay. So the last result, I think, not bad. The third case, the case number 3, Tortuous in the acute setting or acute STEMI, inferior STEMI, primary PCI. First, you can see the left coronary artery very tortuous, but the culprit lesion is not here. But we can predict the right coronary artery also tortuous. And this is the right, as you see, the curve and tortuous in the proximal segment, in the mid segment, and obscure in the distal segment of the RCA. And the first, we are wiring a little bit difficult and pretty wide and pre-dilatation. And we try to print the stent to the culprit lesion with Gidagella, but when the stent go, it gets stuck in the proximal segment because we see the lesion not only the culprit lesion in the second curve. They have the one lesion in the first curve and one lesion in the mid, and the third lesion is culprit lesion. So what can we do? So, and often when we do the many stent, the order of stenting is the distal stent first, and after the proximal stent. In that case, I saw the diameter of proximal and the mid and the distal segment, distal of RCI no very different. So we made decision to stent the proximal segment first to prepare the way for the second stent go. So I deploy the stent in the first curve. After we deploy stent in the first curve, the second stent go easy, and it go direct to the culprit lesion. So the second stent we deploy in the culprit lesion, and the last stent in the mid. So in this case, we can have some learning point. The order of stenting in the tortuous lesion. Sometimes we must stent in the proximal segment first. And the case number 4. I think I enough the time. The case number 4. The same situation, inferior STEMI, a very tortuous coronary artery disease. It's the same in the left, no culprit lesion here, and some lesion, moderate lesion in the mid of LAD, but no culprit lesion. The culprit lesion in the right, and can you see it's very tortuous. And we do a wiring, put the wire. And in this case, we use the support from the extension guide, Gidagella. After we do a pre-dilatation, we can see the blood flow. We can see clear the culprit lesion. So we use the Gidagella. You see Gidagella to go past the lesion, and we bring stent to there. We bring stent to the culprit lesion, and we deploy. And then I think the result is good. And the last case, I think very difficult case. The case The case were referred from the province Kalap. The patient with the chest band, a QMI or maybe a QMI, and were hospitalized to the provincial hospital and provincial cath lab, were done coronary angiogram. And as you see in the lab, total occlusion CTO of the LDD and some lesion in the distal left mat. And the severe tortuous calcified lesion in the proximal, the mid segment of the RCA. And the right coronary artery give the collateral blood flow to the left very abundant. So the doctor, our colleague in the province, to make decision stenting to the left, the right. But because it's very tortuous and very calcified, so they made a stenting the proximal and the proximal part of the mid RCA. And this is the result. So I think the proximal segment and the mid segment, proximal mid segment of the RCA is okay, but the mid and the second curve is still severe. The patient still a check band. And the patient go to refer to our hospital. In our hospital, do we go to the left coronary artery to open, or we continue to the right? And when we check the right, we can see the collateral to the left abundant very much. So I think the complete lesion met the symptom and sign off because the right. So we try to do something in the right coronary artery. Of course, it's very difficult because it's the very tortuous and it have a proximal stand already. So we must go over the stand to the distal, mid and distal of RCA. So of course we use ambulance and 2Y, put Y, and we use the Gidasla from the beginning. But because the guiding catheter not coaxial to the ostium of the RCA, we must use one or more support from eastern guide or Gidasla. And with the support from Amplas and Gidasla, we can deliver to a balloon to the lesion and do pre-dilatation and bring deliver to the first stand to the distal segment and the second stand to the mid segment of the RCA. A little bit difficult. And did the last result. And I think that the distal stand a little bit less, a little bit, but I think it's okay because in this time we don't dare to push the distal distally the stand because I afraid after we do the first stand, the second stand cannot over the curve. So we must put back a little bit the stand so you can see the lesion remaining reason. But I think the collateral blood flow improved very excellent. So that's her message. Small vessel and long diffuse lesion, I have already talked in the beginning. It really challenging for the cardiac interventionist. They easily induce the recession, rupture, long stand within the short term, in the long term, the clinical outcome is very not worse. Stent failure, repeat revascularization is very high, and the most challenge for not only for interventional cardiologists but also cardiac surgeon. A tortuous or very tortuous lesion is the same situation. It may be a long, but it often associates with the small diffuse, long diffuse calcified lesion. It belongs to chip, which means the complex PCI. And the elderly patient is more risk factor for most complex this time lesion. And cardiac interventionist should recognize this type of the complex, and we must predict the complication in PCI to them, and we must know how to manage this lesion and how to manage the complication or obstacle related to this type of lesion. Thank you so much. And I'd like to hear the opinion or a comment from panelists. Thank you so much.
Thank you very much, Professor Hồ Tường Dũng, for a series of very complex PCI in small vessel tortuous. So every complicated PCI that we have to face in our daily practice. So we have 10 minutes for discussing the 5 cases that you presented. So first of all, I want to hear from Dr. Faisal. Do you have any idea of the cases that was presented by Professor Dũng?
Yeah, very nice cases and very tough cases, but very elegantly handled. I think you know, the professor showed many cases where you cannot advance an IBUS, you cannot advance, you don't have the luxury of using all the devices that are available in the market. But I think given those limitations, very elegantly showed how to use support. For example, this last RCA case, using an aggressive guide that provided adequate support, buddy wiring in a very tortuous calcified lesion. So I think a great learning experience and demonstration of many of the techniques that are available. So I think very nicely done. I don't have any question right now, but I'd like to hear what others have to say.
Thank you very much. I already see Dr. Michael Lee is online now. So good afternoon, good evening, Dr. Michael Lee. So
hi.
Okay. So Michael, do you have any comments for the cases was presented by Professor Dũng?
Yeah, I think first of all, greetings from Los Angeles. It's good to see everybody, and I'd like to thank everybody, including Todd, for inviting me. Yeah, I think in daily practice, this really is representative of what we face and we treat. These right coronaries are not the usual semicircles. These are sigmoid shaped, shepherd's crook. So this guideline or Guidezilla has been such a boon for us. I remember we'd have to switch out and take a 8 French guide, but this guide extension catheter has just been such a big bonus for us. I just cannot imagine the days without it. So just so when it's appropriate, it's just a game changer. It's really a disruptor in our field of interventional cardiology. So it's great to see those cases being done, and I think this session is kind of exemplary of what that device can do to help the success of these interventions.
So Michael, you just mentioned about supportive guide like Guidezilla. So do you think that there's any difference in between different types of supportive guide like GuideLiner, Guidezilla, or anything else? Because we have so many devices now. So any difference in daily use of it?
Yeah, I was going to address this in my discussion, but just to get to your question, the GuideLiner is a little more flexible. So when you need that extension catheter to, let's say, traverse a sigmoid shaped RCA, or for that circumflex, which comes off at a 90-degree angle off the left main, it is more flexible. Whereas the Guidezilla, it's generally more pushable. It's more stiff and firm. So situations where, let's say, it's a LAD and it's straight, but it's calcified, and especially those elderly patients that have a large aortic annulus, and let's say an EBU 375 or longer needs to be used. I think those cases where there's not a lot of tortuosity, but more straighter, I tend to use a GuideZilla for those cases. So again, GuideLiner more flexible, and GuideZilla more pushable.
Thank you, Michael. So I want to hear the opinions from Dr. Wu regarding the imaging technique for small vessel. So in the first case, Professor Jung showed a case that cannot doing OCT for left main LED and also left circumflex. Do you have any idea IVUS can help in those cases? Can we use IVUS to define the diameter, the real diameter of left main LED and also the anatomy of the bifurcations of left main diagonal, LED diagonal and left main left circumflex?
Yeah, thank you, Dr. Hui, for your mention about the IVUS. I think in real life, we have a lot of patients with diffuse lesion, calcified lesion, and long lesion, and triple vessel disease. And when we talk about the CABG surgery to the patient, my patient usually refuse CABG surgery. They usually want to get the minimal invasive procedure, for example, the PCI. So I have some case like Professor Dũng presented here, that the patient don't want to get the open heart surgery. So that's a problem. So when we do the case with the calcified lesion, long lesion, small vessel, and triple vessel disease, usually we use the IVUS to get the optimal result for the case. And is your question about the IVUS? I think the first presentation from Dr. Latif tell us about the definition of the small vessel depending on IVUS measurement. So I think the IVUS very useful for the case, especially for the long lesion. We have some data that long lesion we get the IVUS imaging. We have to get the better maze with the intravascular imaging, and I think IVUS very useful for the long lesion and also for the calcified lesion and also for the bifurcation lesion. For example, the first case, I think the first case very good candidate for the imaging to guide the intervention, also get the optimal result. Thank you.
Thank you, Dr. Wu. I think that all of you still have questions regarding the cases from Professor Jung. But anyway, because the program is very long and then there's limitations of time, so I want to move to the next speaker, Dr. Michael Lee from the University of California in Los Angeles. So he's a associate professor of School of Medicine of UCLA, and he's a well-known interventional cardiologist. So his topics will be tips and tricks for optimal PCI for small, long, diffuse tortuous lesion, and his view from the West Coast. Dr. Michael Lee, please.
All right. Again, thank you so much. And it's really humbling to be invited to the session. And again, maybe hopefully soon, maybe next year we get to meet in person. So I just want to share with you some of the tricks that I use to help me deal with these difficult lesions. So what are some techniques to facilitate stent delivery? This is what we deal with in everyday practice, practical tips and tricks. So I really think the most important aspect of successful PCI is you really have to have a stable, optimized guide catheter. And you kind of futz around, play with the guide catheter all day long when you're trying to do a stent. It's really not good. So if you don't have a stable guide, swap it out, get a good guide. It needs to be coaxial. If it's a complex case where you're going to do a 2-stent procedure, if you can go radial, you could use a 7 slender without a sheath. Those are options. If you're going to go with an 8 French sheath through the femoral artery, that's an option as well. My typical workhorse guide for the left system is the EBU 3.5. Excellent support, but let's say you're going to do a complex RCA, an Amplatz guide catheter is very useful as well for these lesions. We've discussed the benefits of this guide extension catheter, the guide liner and Guidezilla. And again, typically what I use is a guide liner for these tortuous lesions because it's more flexible, whereas the Guidezilla, it's stiffer, so it provides more pushability. So that's kind of my rough paradigm in terms of selection of one versus another. Long sheath, I think, are very important, especially when you're doing a radial case and you have a lot of tortuosity in the brachiocephalic. So when you have brachiocephalic tortuosity, you take away the vector forces. So when you straighten out the brachiocephalic and you're pushing, it makes for a much easier vector force to go forward. So let's say a Terumo 150 centimeter sheath is very helpful. Now, obviously, you don't want to minimize the issue of calcification. If there's any doubt, use intravascular imaging, but plaque modification, whether it's rotational or orbital atherectomy or intravascular lithotripsy, if it's available in your geography, is really helpful because you don't want to struggle with these cases. And if you balloon high pressure and you dissect, then the option of doing atherectomy is limited. IDL may be an option at that time. What about wires? If you're having a difficult time getting a wire down, I would suggest using a specialty wire or a workhorse wire with a microcatheter, and then swapping out for a more supportive wire. Another option is to use a buddy wire. Actually use 3 wires. So I like this technique, but it's a lot safer, I think, than advancing a guide liner or a Guidezilla, because you're actually taking a device down into the artery. Whereas if you have 3 wires, it's almost like having a clothes hanger. It's very stiff, but relatively safe. And the concept of a buddy balloon. So let's say you have a wire down and you can't have, you're having difficulty in terms of stability. So actually just take, let's say a 1.5/15 balloon, it provides more stability. So the buddy balloon concept is very helpful. What about the option of a balloon anchor? I think this is very helpful. Let's say you're working on a circumflex, but the patient has a stent in the LAD. You could take a balloon down the LAD, inflate the balloon inside the stent, so there's no risk of plaque perturbation, and that gives you more stability and anchoring effect. But to inflate a balloon in a non-stented lesion, there's always risk of you may cause some disruption and some trauma, and that may require stenting as well. What about breathing maneuvers? What I ask the patient to do is, if they're not fully sedated, is I ask them to take a deep breath in. What happens when you take a deep breath in, you verticalize the heart, so you enhance that vector force concept. Very helpful. And finally, if they're awake and they're able to cooperate, I ask them to cough. And not just a regular cough, but I ask for a vigorous, loud, violent cough, like, and that seems to help deliver the stent or the device as well. But whenever you're pushing, you never want to push too hard because you run the risk of stripping the stent. So let's talk about guide catheter extenders and when it's indicated for. So, think about the right corner artery where it has a lot of angulations and tortuosities. Those circumflexes where it has a sharp 90-degree, even more than 90 degrees, it's very helpful. Interestingly, you could use orbital or rotational atherectomy through, let's say, a guide liner, and it helps to deliver the device, and it almost acts like a 7 French sheath by having a guide catheter extender. What about those difficult chronic pleural occlusions? Well, once you traverse with a wire, and you're having a difficult time crossing, these guide catheter extenders are very helpful. And also you could use it with intravascular imaging. Let's talk about the guide liner first. And as we talked about before, it's more flexible. So those lesions that are more angulated or tortuous, very helpful. And sometimes what I like to do is take the guide liner extender past the lesion. So when you balloon, let's say you balloon first, and as you're withdrawing the balloon, you almost have like a torpedo or submarine effect where you're taking the balloon back, the guide liner sucks in, actually go forward with the guide liner. So that's very helpful as well, because you never want to lose that anatomy and purchase. Let's talk about a case. So this is a patient who had a severely calcified LAD. And you can see there's calcium proximally, but it doesn't look like a lot of calcium there. This is a film from an outside hospital, and you can see that they try to inflate a balloon. There's a dog bone effect. So what happened was the patient was referred to our institution. If you look very carefully here, there's a little contained rupture, right proximal to the lesion. So at that point, given the fact that the patient failed traditional balloon angioplasty, what we wanted to do was to do orbital atherectomy for plaque modification. So you can see here, I'm having difficulty advancing the wire. And I think what happened is that little, that little pseudoaneurysm that contained rupture, the wire is having a difficult time going through. But we were able to eventually get the wire through with the support of a microcatheter. And once you get your wire through at that point, doing atherectomy is pretty straightforward. I mean, once you get a wire down, so we took the microcatheter down, swap out for a Viper wire, and this is the 125 orbital atherectomy going down. And you take your time. This artery was very calcified, very resilient, but we were able to cross. And afterwards, you could see that with the guide liner, you could see the ather was successfully stented. So without these tools, you would not be able to do these cases successfully. All right, what about rotational atherectomy? In this case, the tip of the guide liner is taken too proximal to the lesion, and you could do rotational atherectomy through the guide liner. Typically, I would use a 125. I don't like to use a 1.5. It gets a little tight, but I think a 125 is very reasonable to do, and here's a final angiographic result. Now, let's talk about a technique or concept called the mother-daughter-granddaughter double guide liner technique. All right, so you have a vein graft going to a first OM, and you have a lesion in the distal circ, and there's also a lesion at the bifurcation of the OM and circumflex. So you first take down you first put on an 8 French guide liner. But through that 8 French guide liner, you advance a 6 French guide liner to the wire. And you're taking this guide liner down. Once you have your guide liner down, you could advance an 8 French guide liner to give you more support. So an 8 French guide liner is going through this vein graft OM. Then you have through that a 6 French guide liner. You deliver your device, the balloon, and you have your final angiographic result where you have a stent here and a stent at that bifurcation. So again, a 6 French guide liner going through an 8 French guide liner. This is just another example of a case where you're using an 8 French as well as a 6 French guide liner. So you have to put the 8 French guide liner on first. Then through that, you could put the 6 French guide liner and you just telescope. So once you get the wire down, you could lead with the balloon. And once you get the balloon down, you could advance your 6 French guide liner. And then once you get some resistance, you could use the 8 French guide liner to give you support, which will facilitate the delivery of the 6 French guide liner. So this is a case where there's a chronic total occlusion in the circumflex. And then after the support with the 8 French and the 6 French guide liner, here's your result afterwards with reconstitution of this distal circ. Now, there is what is called a trap liner. And the beauty of the trap liner is, imagine you're trying to advance a 6 French guide liner and you're meeting resistance, so everything starts to kick back out and you get pushed back. With this device, you could inflate a balloon so it's less likely to kick out. So you get more support, and then as you're pushing the guide liner, as opposed to it getting pushed back, you have stability and kind of a foundation, which allows you to advance your guide liner to its desired location. So let's move on to the next type of extension catheter, is a Guidezilla. And I told you about the fact that it's a little bit more pushable as compared to, let's say, a guide liner, which is more flexible. So remember I told you about tortuous lesions. So this is the right corner area. There's multiple angulations here. And this guide liner, because it's more flexible, it can make these turns. It's not as pushable, but it made the turn, got to your desired location, was able to balloon the vessel, and here's your final angiographic result. Now, when you have a vessel that it's difficult to reach with the guidezilla, one option is when you take your balloon to the location of the lesion, when it's inflated, it serves as an anchor so you could extend and advance your guidezilla. And when you deflate your balloon, you could actually, because of the negative pressure effect, the guidezilla could go forward. You also could use the buddy wires. You could use 2 wires to advance. And finally, you could perform rotational atherectomy through a guidezilla. When you're using these devices, you got to be very cautious, because if the stent doesn't deliver and you're trying to withdraw the stent, because the tip is not as soft as, let's say, a guide catheter, you could actually strip the stent. So when you pull back because you're unable to deliver, you got to be very cautious. You just can't pull back arbitrarily. You got to make sure that that stent gets back into the guidezilla and make sure there's no stripping. If you see it, you have to recognize it. And at that point, you have to make the decision, okay, do I deploy it? If it's not an ideal location, then you may have to inflate the stent inside the guidezilla and just retract the whole system back. And you know, if it requires also pulling back the guide catheter, that's less than desirable, but that is an option. So again, these devices aren't without complications. So you got to be very cautious with these devices. So complications, as I talked about. Anytime you're introducing this device, you can cause barotrauma to the vessel. So there's always that risk of when you advance too far and the vessel gets tapered down, it's smaller. The further down you take it, the higher the chance, because it just the diameter of the vessel gets smaller. And then when it's small, you can cause dampening of pressure. So you got to watch out for your pressure, make sure the patient doesn't get ischemic, look for any EKG changes, and work expeditiously to make sure the patient doesn't develop ischemia. Anytime I withdraw a device from the guide catheter extender, I always open up the TUI bores to bleed out, because it's a big device. You're going to introduce air. Always purge out the air, because it can happen where you have air embolism. And again, you know, as we talk about stent deformation, just got to be cautious when you retract the stent. The MAUD database is a kind of a self-reporting database when we have any issues with devices. And you can see here, there's a number of reports of issues with, let's say, the guide liner unable to pass the device, or if there's damage. The devices, the catheter can fracture, dissection is not uncommon, perforation is more or less, I haven't seen a perforation with a guide liner, and thrombus formation. You just have to make sure that you're adequately anticoagulated, and the device, the dwell time should be relatively short. In summary, we encounter vessel tortuosity, angulation, calcification on a routine daily basis. This needs to be recognized. Ways to overcome and complete a procedure successfully. Again, the most important aspect is to have optimal guide catheter support. Guide catheters which have excellent support. My go-to device for the left system is the EBU. And if you're going to do bifurcation stenting, especially with a 2-stent approach, 7 French guide catheters are mandatory. These guide catheter extension catheters are invaluable and really has made a full difference. Thank you so much.
Thank you very much, Dr. Lee, for a very nice, elegant presentation. Actually, I learned a lot. These are, I do quite complex procedures, but I think, you know, you have demonstrated some very nice techniques. I've never used you know, a 6 French guide liner inside an 8 French guide liner. So I assume that, you know, you just advance the 8 French just like half the length, and then you advance the 6 way down, right?
Exactly. You know, people get confused. You could take the 6, then you could put the 8. It's the other way around. You have to put the 8 French in first, because it has a larger lumen, then take the 6 down, then you can take your balloon in. So then you can take your balloon as far as you can, then you take the 6 French guide liner as far as you can, then you can take the 8 French guide liner down, then you have more support, then you can start advancing the balloon, then the 6 French, etc.
Okay, and which wire did you use to cross that Circ CTO retrograde from the SVG that you showed?
Just a workhorse, you know, BMW.
Okay, I would invite anybody who has a question or comment on Dr. Lee's presentation.
Yes, Dr. Macaulay, yes, I learned a lot from your presentation. So I have the question relating to your presentation that the temporary ischemia usually happen when we use the guide extension like STO1, GuideZilla, or guide liner. Could you explain more about this, how to escape from the ischemia, temporary ischemia, because especially when we do with the small vessel, so we stop the blood flow to the distal, to the downstream. And the second question is the trap liner techniques, how to do this without compressing the guide liner and still facilitate the procedure. Thank you.
Great questions. So let's say you're working on a typical right coronary artery. Obviously, if the RCA is 4.0, the guide liner is not going to cause ischemia, but let's say it's a 3.0 millimeter diameter. So you take it down, and if you're losing pressure and it's dampening, the question is, what do? You know, you could work expeditiously. The patient may be able to tolerate 30 seconds, 60 seconds of ischemia. You know, you keep your eye on the EKG first before, and typically I see patients with ischemia on EKG before they have chest pain. So, you know, you see if the guide catheter is stable and with the pressure, take your guide liner, and if it's stable, no EKG changes, you feel comfortable. But if it's dampening pressure, you have no choice. So you just got to work quickly, take the balloon down, guide liner down. Once you get the balloon to its desired location, then I'll pull back the guide liner into the guide. Then you have restoration of normal perfusion. So it's kind of a juggling act, balancing back and forth. But the least amount of time that you have the guide liner in the artery, the better. But there are times where nothing goes down. And like I said, when you pull the balloon back and you advance the guide liner, it's actually helpful to get the guide liner across the lesion. And the patient might have a little bit of chest pain. So that's when the nurse, you know, you have to tell the nurse, hey, have that 3.0 by 18 designs ready to go. Have it on the table as opposed to them having to go outside the room. So just be prepared. But you know, it's all a balancing act, and it's a clinical judgment. The trap liner is actually a specialized device. It actually comes with a port so you can inflate. So it's a dedicated device which has a balloon connected to the guide liner.
Yeah, thank you.
Hi,
Question
Michael.
about rotablator. Can you put a 1.5 burr through a 6 French guide liner? Does it work well, or do you use a 7 French in those cases?
Would use a, well, put it this way, I would use a 1.25. I've heard of people using 1.5, but it gets snug. It's analogous to people using, let's say a 1.75 burr inside a 6 French guide catheter. It's very snug. It's very uncomfortable. My experience has just been, well, to be quite frank with you, you know, I've switched pretty much all my interventions to orbital atherectomy. But in my experience that I've used it, 1.25, once you get a 1.25 in, it's going to cross. So I don't have a lot of experience with 1.5, but 1.25 definitely is doable.
Got it.
I have a question.
Yes.
Thank you for your very practical presentation. Now I want to come back to the first illustrated cases with the calcify and angle lesions on the LAD, and you have a small rupture after predilation. Practically, we can have dissection or small rupture at the angle after predilations. And if we rewiring, there is a risk of go to the false lumen and then go back to the true lumen. And the wire keep going, and we cannot recognize it until the stenting is stuck at that location. How can we avoid this complication?
In this particular patient, he was not a surgical option. So you just got to be cautious. And you saw that, when I was having difficulty advancing the wire, I hit fluorostor to demonstrate to the people that it was going to be difficult. You just have to use a workhorse wire. I would discourage using a hydrophilic wire, because once it goes in a little channel, you would never know it. So just using something like a BMW, and just you get the feel. And if you're not sure, advance the microcatheter, and you can always inject through. Or when you take the wire out, you'll see blood come back through the microcatheter, and that gives you a good idea that you're in the true lumen. But it's also just a feel. And once you get the wire down and you're torquing and spinning the wire, you can see it's moving freely, the tip's free. But there's any doubt, you can see blood comes backward, but also just get a 5 cc syringe of contrast as just inject through. And there's always a risk of catastrophe because you have disruption of the medial wall. But that's where you want to be very cautious about doing too much runs with the atherectomy device. So again, you're just making a little plaque modification. You're not looking for perfection. You just want to crack it, and then you could do your ballooning, etc.
Thank you.
Any other questions for Dr. Lee?
I have no question, but I like to have one comment. I think the question from Dr. Ngô Minh Hùng and the answer from Dr. Michael Lee very important, because the young interventionists should pay attention to this. Because when we do PCI to small, diffuse, calcify, tortuous, the most of the tool and the most of the strategy it look like similar to the CTO. But the important thing, the different important is between the CTO and small, diffuse lesion and tortuous is if you reduce the blood flow, the acute ischemic crisis will happen and the terrible. But in the CTO, you can do it slowly, or maybe 1 or 2 or 4 hours, no problem. But when we intervention to the small, diffuse, tortuous lesion, we should pay one eye on the ischemic crisis. I think this question and answer is very important for the young interventionist. Thank you.
Exactly. They say the first manifestation of ischemia is EKG changes before chest pain. So you always want to be familiar, and also if they get bradycardic, that's a manifestation of ischemia. So, we look at not only blood pressure, but also the EKG. And then even if the EKG, let's say, they have artifact, that's why it's so important to have the nurses fix it before you're doing these more complex lesions.
And sometimes we can have a plan A, B, C, D, but if it be ischemic, the acute ischemic crisis happen, you must try to open to keep the flow standing immediately. I think so. We must change the strategy. Yeah.
It's much easier to prevent ischemia as opposed to treat ischemia, right? So, yeah. So if you have, let's say, dampening with that guide liner, for example, you want to move as quickly as possible or withdraw the guide liner, and it's a fine medium. If you don't want to cause ischemia, but you also want to be able to deliver the stent.
Yes, I understand. But sometimes when you are eager to do to push the stent or deliver stent, sometimes it gets started some trouble. So we must prevent before we are in the middle of way. We cannot come back. We cannot go forward. Yeah.
Can I have another comment on the ischemia of the vessel, the gallbladder vessel? Yeah, usually in my clinical practice that I use the balloon and inflate for around 15 seconds or 30 seconds in order to test that the patient can tolerate with that or not. Before we use the extension guiding, because we at that time we usually we don't have time in order to test for the patient when we put the guy attention. So in my clinical practice that I use balloon inflation for around 15 or to 30 seconds, and then we see how the patient can tolerate with that. That's my technique. Just ask for the young interventionist like Professor Jung just mentioned that. I asked this question for the young guy. Thank you.
Certainly, great talk and great comments. So let's move on to our next talk. We have a little change in schedule. So our next speaker is Dr. Din Tuc Hoi, and he will be discussing about stentless PCI strategy to small vessel coronary artery disease. Dr. Hoi.
Yes, thank you very much. Thank you for allowing me to attend in this session. And also thank you, Dr. Hung, for changing the slot for me. So my topic in the next 15 minutes is the stentless PCI strategy for a small vessel CAD. So all of you know, the first PCI was done by Andreas Wunzig in 1977. And we all know that with this kind of procedure, balloon did a great job. So even with just a balloon, that Dr. Wunzig can open the blockage of the artery, and the result was great. But we know that restenosis so far is still the Achilles heel of conventional balloon angioplasty, and also with the bare metal stent, with a risk of restenosis of 30 to 50%. And then when we move on to the era of drug-eluting stent, then we have to face the stent thrombosis. And even with the newest generations, the stent thrombosis, even very low, is still the nightmare for all of interventional cardiologists. So can we not to stent the vessel? So in concept of leaving nothing behind, with a single balloon inflation, that we can give the drugs to the vessel wall, and hopefully with this kind of mechanism, patients will just need a shorter DAPT durations. And when we have no stent, that patient definitely have no risk of late stent thrombosis. So why treatment of small vessel disease? What we agree that the diameter of less than 2.75 mm is a challenging problem, because we will face with higher risk of restenosis and TLR. So let me explain a bit more for this. So if we have a 1 mm of late lumen loss in a 3 mm vessel, it can be 33% of lumen stenosis. But in a 2 mm vessel, 1 mm of late lumen loss would translate to 50% of stenosis. So it reached the definitions of in-stent restenosis. So patients have a higher risk of MACE. In some of randomized trials, then drug-eluting stent give benefits for small vessel. And in a small study, bellow, drug-coated balloon paclitaxel also doing the same. So far we have quite numbers of drug-coated balloon for a small artery. So we start with a picoletto, after that bellow, restore single small vessel disease in China. And the biggest one, the randomized control trial, is Bacchus Small 2. So the bellow study is a prospective multi-center and randomized study, include 182 patients with small vessel lesion. And in this study, the paclitaxel drug-eluting balloon was compared versus a paclitaxel eluting stent. So the primary endpoint is a non-inferiority of angiographic in stent or in balloon lead loss with a delta of 0.25 mm. And the secondary endpoints is angiographic restenosis, TLR, and MACE at 6 months. And as you can see, when we compare drug balloon and drug stent in small vessel, the P of non-inferiority was achieved. Even the P for superiority also get in this bellow study. In China, they have restore small vessel disease randomized controlled trial in 12 sites from 2016 to 2017 with a number of 230 patients. And for the 9th-month in segment diameter stenosis is the primary endpoint. There's no difference in between the drug-coated balloon and drug-eluting stent. Also at 1 year, target lesion failure included cardiac death, target vessel MI or TLR. There's a comparable result of drug-coated balloon and drug-eluting stent. The bucket small 2 study so far is the biggest one. It is a multi-center open label and randomized non-inferiority trial with nearly 800 patients with de novo lesions in small artery. So all the lesions were successfully pre-dilated, and after that randomized to drug-coated balloon versus a second generations of drug-eluting stent. And the primary endpoint is a MACE, including cardiac death, non-fatal MI, TVR after 12 months. So this is the primary endpoint result. So MACE after 12 months is happen in 7.5% in drug-coated balloon and 7.3% of drug-eluting stent. So no difference in between the 2 arms. When we see to the components of primary endpoint, cardiac death, non-fatal MI or TVR, definitely there is no difference in between drug-coated balloon and drug-eluting stent. Even the major bleeding at 12 months is almost the same between stent and balloon arms. So this is the first large randomized study to test the efficacy and safety of paclitaxel coated balloon versus a second generation drug-eluting stent in all comer population regarding clinical endpoints. And in this study, drug balloon are non-inferior to drug stent in lesions of small arteries. So they concluded small native arteries may be safely treated with drug-coated balloon after a successful pre-dilatation. The meaning of this study is that no permanent material implanted in artery potential translate into a reduce of number of late adverse events. After 3 years of follow-ups, data show there's no difference in between drug balloon and drug stent. And if we see to the right of screen, we can see that drug balloon have a comparable results with the Zymes, one of the standard we call the gold standard of drug-eluting stent. So after 3 years, we have a similar result of cardiac death, non-fatal MI, TVR, on-cause death, stent thrombosis, and major bleeding in between of patient receive drug-coated balloon or drug-eluting stent. With a very small artery, line 2.0 millimeter diameter artery. Our colleague in Singapore also doing a study show that the paclitaxel drug-coated balloons is not different from sirolimus or zolpidem drug-eluting stent. With a meta-analysis of nearly 2,000 patients in 7 studies, we have similar risk of TLR and similar MACE of drug-coated balloon and drug-eluting stent. So for bifurcation lesion, when we have a small side branch, this maybe can be another application of drug-coated balloon. So this is angiogram show side branch of 2 mm diameter, and the doctors do the procedure by stenting the main vessel after the port, and then doing the side branch with a paclitaxel drug-coated balloon and port again, and they call port side port for bifurcation. So the pictures looks really nice. So this is a plan for stentless PCI with drug-coated balloon suggested by Jaeger in the year of 2020. So all the lesions must be prepared well. You can use either scoring balloon, cutting balloon, non-compliance balloon to open the artery. If you get a acceptable angiographic result, it means no flow limiting dissection or residual stenosis of less than 30% on FFR of more than 0.8, then DCB can be applied with a short delivery time and sufficient inflation time. Normally we do it in 45 to 60 seconds. If we got a suboptimal angiographic result after balloon dilatations, then Druxen can be used. So in market now, not only the duct cells, but we also have the sirolimus coated balloon. And we do see some of the very new data coming to support the sirolimus coated balloon. And in the SERPAC study, an indirect comparisons between the duct cell and sirolimus coated balloon, we don't see any difference in between the clinical endpoints of 12 months of follow-up. Definitely, we have to wait for long-term data. So the SENLess PCI strategy with drug-coated balloon for small vessel CAD is based on the concept of leaving nothing behind. If you want to apply this, we need to prepare the lesions very carefully. It's a must. Patient will get benefit with short DAPT times. Normally, we need only 4 weeks, and patients have no risk of stent thrombosis. It's based on the result of the basket small 2 study with a similar mesh between drug-coated balloon and new generations of drug-eluting stent. And the result of basket small was maintained after 3 years of follow-up. So thank you for your attention.
Well, thank you, Dr. Hui, for a very interesting presentation. That shows a good option for a small vessel is DCB. The paclitaxel coating balloon exists in the market is for than 15 years, but the sirolimus is just only 5 years, and we are waiting for the results from the big control trial concerning the sirolimus. I think the indication of DCB is more and more confirmed by the trials for the small vessels, especially if the vessel is a side branch of the bifurcation with a diameter is less than 2 millimeters. But do you think there is other indication for DCB in de novo and in the main branch of the coronary arteries? For example, this morning, we see the presentation from Professor Jung with the very diffuse lesions of all 3 vessels. And Professor Jung implanted the stents for the proximal segments. But I think if the distal segments, if we can have a good preparation with pre-dilations, then we can apply the DCB instead of the DS with the long segment.
Thank you very much, Dr. Lloyd, for your comments. So I totally agree that with diffuse disease and distal lesions, if we have a good preparations of the lesions, and then we have a good flow, then DCB can be a good option. Since some of the situations that we are not sure about the dissections, or then the IVUS or OCT can give us an idea. So if this is a non-flow limiting of dissection, then I think so we can just leave the lesion alone after balloon and then after the drug balloon. But if we see a nasty dissection, then Druxen will be better, I think.
I would like to invite Dr. Michael Lee to moderate the discussion session. Michael?
Yeah, so the use of drug-coated balloons, at least in the United States right now, it's not currently available. I just want to see in Asia and Vietnam, is it currently available, and is it used primarily, I would imagine, let's say for small vessel disease, but also let's say small side branches after stenting of the main vessel. But any thoughts from Vietnam? And Tak, tell me your thoughts about your possible an application in the United States if it becomes available. Tak, why don't you start first? What do you see the role of
for balloon?
Yeah.
Again, we don't have any experience, but they do the balloon angioplasty for, we do radiation balloon in the peripheral arteries. So I really appreciate your question, but I have no no experience. So we have to ask the Vietnamese team or the one like he has experience with the team in Singapore.
I have one question for Dr. Linda Hui. I have one case, the first case, the case number 1, the long, small diffuse lesion, but in the acute setting, acute MI. So in your presentation, it seems you did not mention about acute ICS acute coronary syndrome. So how do you think the coated balloon can use for the long diffuse lesion in the acute setting?
Thank you very much for your question. So I think in the acute settings, the most important is a flow. So even in the very first years of primary PCI, so when we only have the balloon with no stent, then the balloon works. So I think if you believe that the vessel size is really small and there's some problem of putting the stent in, and then balloon can give a good flow for your artery, then I think that there's no contraindications for apply drug coated balloon for your left main or LED. I think when we want to use this kind of strategy, then the IVUS or OCT will give more details for us.
You know, one particular application I think is the following. You know, let's say you have a kind of a small ratty pruning of the LAD and it doesn't really accommodate a 225 stent. Those cases, in my experience, when you start stenting these lesions in diabetics, if your runoff is poor, these are the patients that come back. So I think it's very important to have good runoff. If you don't have good runoff, I can imagine if it's available in the United States, it would be these lesions that I think a DCB would be a good option. Because invariably, if you have poor runoff in these small diffuse diabetic vessels, these are the patients that come off. And also, you don't want to take away or burn bridges of providing an option for future CABG. So taking away that distal target for a surgeon, I think a DCB would be a good application.
I have a comment with Michael.
Yes.
Do you know the reason why the FDA has not approved for the DCB? What are
it's going to require
a
a pivotal trial in any introduction of new technology. And I think the issue of there was some concern, at least in the United States, about the DCBs in the peripheral arterial disease. Subsequent studies disprove this mortality, increased mortality relationship. But I think there's going to be a lot of scrutiny. So there will require, FDA will require a multi-center study to demonstrate its safety and efficacy. And that will take a lot of, resources and time. But, Europe and Asia seems to be always 2 steps ahead of the United States. There's always lag behind. So it's going to require an RCT. Tak, what are your thoughts about future role of DCBs and the role of FDA?
Sorry, Michael. I do more about research and clinical research. I understand the politics of approving data because for the Vietnamese team, interestingly, they have in Vietnam, there is a company producing a drug-eluting stent. And this team here, many panelists here, they are investigator of the clinical trials of the new stent, including OCT and IVUS. And the results were great. I'm so interested in that. And let's say this is why we asked how to bring this stand to the US. Then we have to go to the FDA. We did talk before to Ron Waxman about this, and he is very interested. He was very interested, you see, but it is not easy to compete with a big guy in the US now or in Europe. So same for the balloon. If this balloon is working in the small vessels, it will be applied to the big vessels too. And this will be a threat to the stand company. So let's say, for example, now this type balloon, the truck balloon here in small vessels, and they work also in big vessels. So it will replace the stand and the other one, the new one that was discontinued. The balloon with the stand with reabsorbable stand platform. So it's very interesting. It is a big fight, and it involving a lot of politics. And one of the way how to do it, you know that HCRI with Michael Gibson, now at Bain Clinical Research Institute, DCRI, or C5 of Cleveland Clinic, or the team from TCT. If the company want to bring this product into the US, they have to go through all this big name and big monies to do that. So this is how I look. And,
you know, one application of DCBs, I think, maybe, let's say in the setting of acute MI, it's predominantly thrombus, and you do a balloon angioplasty, that you get restoration of flow, and you don't necessarily need to, let's say, stent. If you restore flow, and let's say you have some thrombus, and you probably can macerate the thrombus with the balloon, and you have, let's say, a 20% residual, perhaps it may be in these situations where not putting a metallic scaffold in, but using a DCB may be an option. I think that would be one application that I would consider looking at. And so it's interesting how we've kind of come full circle. It's been balloon and stent, and now we're thinking about doing less is more, similar to de-escalation of DAPT. So maybe that's a role down the road where if you have a good angiographic result, that that it doesn't require a stent after, let's say, a STEMI.
So I have one comment about the DCB in acute coronary syndrome. So I agree with my colleague about the flow after ballooning is very important to make the decision between the DCB and the drug eluting stent. So as we know that in the presentation from Dr. Hui, we have the basket small 2 trial, and in that trial we have over 700 patients, but we have also over 200 patients with acute MI in this trial, and over 100 patients with non-STEMI. So they do have the comparing between the acute coronary syndrome with coated balloon and coated stent in this trial, and they show that there is no difference between the outcome in the acute coronary syndrome when we use the drug-coated balloon compared to the drug-coated stent. So I think this is a good point. We have the largest, the biggest trial, and we have a subgroup with the acute coronary syndrome with the safety of the drug-coated balloon in this situation in acute coronary syndrome. So thank you.
What about side branches? I think it'd be a good option to use it in side branches in a bifurcation with a single stent strategy as opposed to a 2-stent strategy. So that would be another option. You know, if you have, let's say, a 40% residual and an FFR is negative, dilating the ostium of this, let's say, the side branch, like the diagonal branch, would be, I think, an application for this DCB technology also. Any other thoughts from my colleagues? anything else about DCBs that you would give us some, at least people in the United States, applications that's used in, let's say, Vietnam or Singapore?
So I have a question for Dr. Huy. Yes. Before DCB, we have to pre-anate. So can you show me how to choose the balloon, non-common balloon, or NC balloon, or common balloon, and what size? 1:1 to diameter, feather, or smaller, and how often you go up for DCB, please.
Yes, thank you, Dr. Van. So I think, as I mentioned in the talk, so preparing the lesions before DCB is the most important step. So so normally in my daily practice, I will use the diameter of 101 the vessel size. So if it wants to apply the DCB, then I think the IVERS will give a very good idea of how big of the balloon that we should choose for pre-dilatations. So let's say if the vessel size is a trio, then we will try with the trio balloon before we go with the drug-coated balloon, because we believe that the drug balloon is not the balloons used to open the vessel, but just a device to deliver the drug. So the final results all based on how we prepare the lesions. So then non-compliant balloon can be an option, but in some of, especially in calcified lesions, then I think cutting balloon or scoring balloons can also be used, because when we use cutting balloon or scoring balloons, then the dissections can grow rather than non-compliance balloon. We see more of flow limited dissections non-compliance balloon than with cutting balloon and scoring balloon. So choose the same size of vessel scoring balloon or cutting balloon before, and then if we have a good flow, then we can apply the drug-coated balloons later on.
Anybody else with some thoughts? Yeah, Dr. Dong?
Maybe one more question for Dr. Huy. Do you have an experience to use the DCB in instant restenosis?
Yes. We have quite a number of patients with restenosis, both bare metal stent and drug-eluting stent. Especially when we have to face a small stent, like a 2.5 to 7.5 breathless stent, then we would think of doing a drug-coated balloon for in-stent restenosis, because we definitely want to minimize the stent, the material, stent material in the vessel wall.
And the instant restenosis in the severe grade, do you need to use the cutting balloon or scoring balloon before you inflate the DCB?
The answer is yes. Yes, we when we see instant restenosis, is a very short one, then I think the cutting balloon or scoring balloons will work, because when we apply for conventional balloon, it most of the times we see the slipping of the balloon over the restenosis. So cutting balloon and scoring balloons will have to open the stent again.
Yeah, I think the cutting balloon or scoring balloon in the severe restenosis, instant restenosis, it's very useful. It can match the capsule, the cap of the plug rupture, and after that you inflate the DCB, and the rod can invade to the plug. If we don't use cutting balloon, sometimes you use NC balloon, the neo plug cannot, the caps is intact, and so the drug cannot invade to the plug. I think so. Okay, thank you so much.
All right, I think we could wrap it up. I just want to thank you so much to meet friends, new friends and new faces. And it's been a very educational session. And I want to wish everybody to stay safe and be well. And again, I'm very humbled to be invited to participate. And I hope everybody's doing well. Thank you so much.
Thank you, my colleague. Thank you.
All right. Thanks.
The next speaker, Dr. Ngô Minh Hùng, with the Tortuous vessel PCI, how to handle. See, Dr. Ngô Minh Hùng.
Yes, good morning and good afternoon, chairperson and faculty and audience on online. This in my clinical practice that we have to cope with a lot of tortuous vessel, and this is one of the case that I want to show with you that they have the left main disease and then the LED very tight lesion. And my colleagues already failed twice to wiring the lesion with this anatomy. So I do the animation that this is the left main, and this is the circumflex. This is a brain that we can say that is the remus, or this is the early OM also okay, but with acute angulation from the left main to LAD. But the patient denied to undergo the CABG, so we have to do the intervention. But my this procedure already failed twice, so now we have to do the intervention for the patient. How we deal with this kind of anatomy and patient. So this is the lesion that you can see that the very acute angle from the left main to the very proximal LED, and the wire cannot go through because when the wire we have the band level very curved, and it can go to the atrium of the LED, but when we push it, and it prolapse to the remus or the prolapse to the circumflex. So if the wire cannot cross the lesion, so how can we deal with this lesion? So we have to learn from the previous procedure. So once again, this is the anatomy of the lesion, and we use a lot of wire. The run through the PT2MS, the Fuder XT, Gaia 1, even the Gaia 2nd, in order to deal with this. So I received the patient. So a real tortuous lesion is the real challenging subset in PCI. The tortuous lesion is also the indication. Also an indication for the revascularization. However, this my patient, he didn't want to undergo the CABG, so we have to do the intervention. Surgery is often considered in this set of lesion, especially when the other main vessel disease coexists. Besides for this kind of lesion is definitely one of the more challenging procedure. So go back to the definition of the tortuous band vessel. So usually two or more band more than 70 degrees proximal to the target lesion, or at least two proximal band more than 90 degrees, or the presence of the significant vessel curvature proximal to the target lesion. So on the basis of the number of the 45 degree bands, so usually we so serial bands like previous presentation that we see a lot of severe tortuous like this. So no or mild, so usually 1 or 2 points. So moderate is 2 bands, and severe more than 3. So before doing the kind of procedure, so we have to pay attention the anatomy, the block layout or composition, and the patient's clinical status as well. Because if the patient cannot tolerate with the procedure, so we cannot do the procedure at enough time in order to cross the device and then the stent. So most of the time we have to use the strong backup like the previous presentation that for the left side, so usually it's CLS or EVU or even the BL or something like that. So, but the right side, sometimes it's a little bit anomaly. So we have to select the suitable guiding catheter like this, JR or even AL. or EBU for the right side. So in some situation, we have to use the hockey stick amblast, left venous bypass graph, or even the XPRCA. So this is some of the technique that I usually use in the clinical practice, that we have to use the passive guide support or active guide support, or even the mother and child. We use with the XT01 is the very cheap compared with the guide liner or guide Zilla or even guide flush. So and some we don't have the balloon proxic balloon. So we use the anchoring techniques. So with the very often in clinical practice. So in order to deal with this, the tortuous lesion and tortuous vessel, so we have to use the shorter and thin plug stent, and shorter and lower profile balloon or stent as well, and anchoring techniques. But I usually stay away from the stiffer wire because it causes a lot of the spasm of the coronary arteries at the time, leading to the significant complication, dissection or something. And a lot of the time we see the pseudo lesion. So we have to memorize the coronary artery anatomy, and then we put the stent correctly to the reference picture. Advancement of the microcatheter at the previous presentation, Dr. Michael Lee and Professor Jung also mentioned about that. We use the microcatheter. So in Vietnam, so we use the catheter. We don't have the turnpike. Then with the high torque wiggle wire, I used to use this kind of wire, but now it's not available in the cath lab. So over the wire devices, they also often used in the clinical practice because it's very easy to push for the lesion. And the laser or rotablator, here we don't have the laser, but we have the rotablator. So sometimes I use the rotablator in order to facilitate the proximal segment in order to deal with the distal lesion. And active guide or passive guide catheter is usually used in clinical practice. So body wire as well, we use 2 or 3 wire, because the 2 or 3 wire, so we can take the wire, the first or the second wire out, and we adjust the curvature of the vessel with the wire inside, because with very strong wire using, so we cannot adjust the support of the wire. So with the 2 or 3 wires, so we can adjust the wire inside the vessel and then the curvature of the vessel as well. So another technique is body in gel. So this is the very strong, very good technique for the very tortuous lesion, but the uses in attention. So we usually deliver the body wire to ensuring it's in non-hydrophilic and non-hydrophilic and at least the medium support. Deploy the stent in the proximal segment of the stent of the artery, thereby gelling the body wire. So we have the very strong backup. Leaving the gel body wire inflate, deliver the second stent to distal segment through the proximally placed stent, and then after the removing the body in gel wire, deploy distal stent. So both dilate stent with the high pressure balloon, and then they confirm the result with IVUS. So this is my strategy for the tortuous coronary artery. So usually we have to select the suitable guiding, the wire, the lesion. We have to know the anatomy, and then the stent. Very important that we have to use short stent and thin stent stroke in order to cross the very tortuous. So go back to my patient. So we send the patient to undergo the CT in order to know that the anatomy of the vessel. So we put the patient back on the table, and then the third procedure for the patient, because the first two already fell with the normal wire. So this is the problem. So the wire can go to the atrium of the LLD, but it cannot cross the lesion because it keep prolapsing into the remus or the circumflex. So this is the picture. So as the Dr. Latif or Dr. Michael already mentioned about that, we use the sewer wire. This is the sewer wire. So I use the balloon inside the remus in order to stop the prolapsing of the wire, and then use the sewer wire in order to go through this. You can see that after go through this, so we just pull back, slightly pull back the wire, and then advance the microcatheter in order to cross the lesion. So this is the final picture, and very good picture. So go back to the anatomy. So I put the wire into the remus, put the balloon in, and then I use dual wire, keep pushing into the remus, and then the wire go back and go to the LED, and then pulling back the wire, make it straight, and then advance the microcatheter, and then we finish the procedure. And the next patient is the very tortuous, the circumflex lesion with the small branch around here. And the patient didn't undergo the CABG, so we have to do the intervention for the patient. So we put the wire, cut through the wire to the lesion very easily. However, we cannot cross the lesion after multiple ballooning for preparing the lesion. So we have to use the guide plus in order to go to the lesion like this. So and with the body wire as well. So we deploy the stent. So this is the final result, and we post dilatation, and the curvature of the vessel still there. So this is the procedure. So after preparing the lesion, the stent cannot cross. So we put the guide plus inside the circumflex, and then deploy the stent quite easy. So another case is that the right coronary artery with the very distal lesion to the distal segment of the RCA as well. So we have to do the ballooning, but they cannot cross the lesion with the long stent. So once again, we use the guide plus in order to put it inside the coronary artery, and then we deploy the stent distal to proximal. So that is the final result. And another case that the very tortuous from the left main to the LED, and you can see this, and we put the IVERT in, and this is the 360-degree calcification. So we use the high pressure balloon, but balloon cannot cross the this segment. So we have to do the rotablate. We rotablate the atrium, and then we do the ballooning, and we put the standing. So the curvature of the left main and LED is still there, and the circumflex is limit 3 flow, and we put the standing from the left main to LED. So this is the rotaplator. It cross the distal left main to the LED. We have to go slowly because if we go so fast, so it can stuck inside the LED if it cross the left main lesion. So this is the final picture. So to conclude, the tortuous vessel PCI is the real challenging procedure in clinical practice. So prior analysis on the anatomy, composition of the lesion, and patient's condition help us to properly select suitable devices and technique. And successful deliverability of stent without complication is essential of the procedure. Thank you very much for your attention. Thank you.
Thanks so much. Thanks so much, Dr. Ngô Minh Hùng, talking about how overcome the difficult lesion. So, and very good, very great, excellent presentation. So any comment from the colleagues, American colleagues and Vietnamese colleagues?
Yeah, I want to have a comment with the presentation of Dr. Hung. I learned from your presentation that your strategy of stenting is the proximal first and the distal later, right?
Yeah, it's up to the patient. Usually if we have to cope with the calcified severe calcification at proximal segment, so usually we have to open it up. Otherwise, we cannot cross the lesion, the balloon to the distal segment of the vessel. So sometimes we have to stent or ballooning or even preparing the proximal or finish the proximal first and then the distal later. But sometimes we have to do the prepare the lesion proximal, but we put the stent distal first. Yeah. Because when we put the stent proximal, so at the time we cannot cross the proximal
it's the
segment
same
with another stent.
Yeah, it's the same situation as in the presentation of Professor Jung. But in this case of the proximal first, the distal later, how can you select the length of the first stent? Is shorter or is longer? Shorter is better or longer is better?
Yeah, very, very useful, very good question. Because if we choose the too short, so usually we have to use so many stent. So the problem is the stent overlap together. So the overlapping segment is another issue when we do the intervention for the distal segment. So we have to put the stent through the curvature that we want to. Otherwise, we put the stent and then we put the second stent. So the second stent stuck overlapping with the first one, and then have the very stuck the balloon or devices go through that segment.
Thank you.
I have one comment. I think the presentation of Dr. Ngom Hong is very excellent. The wiring is the first step. The interventionist should pass the patient. But if we cannot wiring, when we cannot do anything, because everything, every instrument, balloons, then go on the wire. So it's very important. And some case we do the wiring very difficult, such as the case of Dr. Ngom Hong. It's a trifurcation, and the wire or have the chain go to one direction, not go to the front with the lesion. So Dr. Ngom Hong use the second wire and use a small balloon obstruct the right another direction and to make the wire go to the wire with the lesion. Very excellent. And so young interventionists can learn the tip and trick of this situation. And I think Dr. Ngom Hong should give us some command to choose the balloon for the young interventionist, because if you use the balloon not suitable, look like a long, particularly in this situation in the left man bifurcation or trifurcation left man, it can match some disaster. Dr. Hong, can you comment about balloon?
Yeah, thank you very much, Professor Jung, about the intervention. Usually, this presentation, I actually mentioned about the wiring first because everything happened later because based on the first one. So usually with CTO, we accept the failure around 60% with the wiring because we cannot wire the lesion, so we fail to do the next step. So wiring the lesion and then exchange to the workhorse wire first, and then we do the next step. So talking about the balloon. So usually I use the short a little bit like 12 or 15 millimeter in length in order to prepare the lesion. We and see how it works before we upside to the bigger one and longer one. So But the stand is the very important issue, because as I talked to Dr. Le, that if we choose the two shock stand, so we use too many stand. So we have to look at the anatomy of the vessel. So the stand have to pass through the main curvature that smoothly. So the next step will be the balloon or something like that will be okay. So usually I use the shock balloon in order to repair the lesion. Not very too shock, but around 10 to 15 millimeter in diameter, in length, and then 1.5 or 20 mm. Thank you.
Yes, I have to comment. So in procedure for complex lesions, you use very technique, very deep and tricks. And one of these you use body wire technique. And so you can comment what wire you use, non-hydrophilic or hydrophilic wire, and why?
Yes, very useful question. I usually use the like a run through and not the hydrophilic wire, but the hydrophilic wire is used for the tortuous vessel, but we don't use that for the gel wire. We use the like run through or just a normal wire, and we adjust the curvature of the vessel. Sometimes we put the wire to as distal as possible, but sometimes we have to keep the curvature of the vessel, so we have to pull back the wire in order to keep the curvature of the vessel in order to realize again the lesion in order to boost stand. That's the benefit of the 2 wire or 3 wire compared with one very strong wire. Because one strong wire we cannot adjust the backup of the trackability of the wire compared with the 2 or 3 wire. 2, 3 we can adjust, we can pull it back and then adjust the curvature of the vessel. But I don't use the hydrophilic wire. And another thing is when we use the gel wire, body in gel wire. So when we take the wire back after we deploy the stand, so I usually keep the balloon inside the stantic segment, because in case that it damage the stand, so we have to use the balloon in order to open it up again. Thank you.
Because because hydrophilic wire is easy to talk and more checkabilities and easy to in your pull back after standing. Why you don't use?
Yes, I don't use that because the caution about the wire, and of course sometimes we cannot control the tip of the wire, because when it goes distal, so with the tortuous and the guiding keep sucking in, so the wire keep pushing in the distal and go the distal perforation. So I don't want to use that, because in order to get the strong support, so we have to put the wire distally to the vessel, but that the risk of perforation. Thank you.
Yes, thank you. And other comments from colleagues?
And I have one comment about the last question of Dr. Wang. And hydrophilic wire is very excellent to go forward, and it's very good in some difficult case. But with the good characteristic of the hydrophilic, in compromise, it's very easy to get dissection go through throughout the vessel. So I think we step by step. In the further 2 steps, we use non-hydrophilic is more safer. And if very difficult and you try many kind of wire, hydrophilic may be the last choice for us to manage some difficult situation.
Yes, I agree with you and with Dr. Minh-Hùng. I asked Dr. Minh-Hùng that because some young doctors can some doctors can use want to use hydrophilic wire for tortuous. So tortuous, why he looked quite easy to proportion, little proportion. As we talk to we cannot control the type of Y. So I want to Dr. Myung recommend that short use hydrophobic Y in toxic region and difficult regions.
Yeah, thank you, Dr. Wang Wang. That just asking me to give the learning point for the young guy.
Yeah. And I have one question for Dr. Myung. I think for the bird white techniques, and can you show us how to make a curve of the bird white technique before you put the calorie? How to make a curve?
Say it again.
In
reverse wiring.
Yeah.
Okay. Thank you. Yeah, understood.
The curve. Yeah.
Yeah, the reverse wiring actually with the first case that I show on my presentation that I use the normal reverse wiring, that I use the hydrophilic wire. I make the very 180 degree and go to the to the reverse and then pulling back and go to, but it go to there. But when we keep pulling back, it cannot go to the LED. So we fail with that technique. So we have to use another technique that the reverse wiring with another balloon in order to support the bouncing back of the wire, like a previous presentation that we use this very soft wire, and the wire keep finding the optimum of the LED and go to the digital LED like we do the retrograde. So that's in my thinking. So it worked quite well. So I think next time you can try it with this, because it find the optimum of the LED and it go inside without any technique. So we just keep pushing to the balloon, and then balloon and the wire finding the way to go. So at first go to the circumflex, so we don't use that direction. We pulling back and keep pushing again. It go to the LED. So we keep going to the LED with the very easy. Thank you.
Yeah, thank you for the new techniques from Dr. Myung.
Yes.
Yeah. I think
so I call that the balloon assisted technique. I think
Yes.
some interventionists also use that, but I don't know the yield with the suo or not.
Yes, thank you so much. I think now it's time to go to move other pretensions. Không biết là giờ này đến present có ai anh Dũng nhỉ? Bởi vì đổi mất lịch.
Chắc là tới bài cuối cùng là của thầy Thạch. Còn ông Cameron thì chắc là can thiệp bằng cấp cứu là không quay lại kịp rồi.
Yeah. Now it's time to move as a presentation, Dr. Thạch Nguyễn, with certification and tactics PCI in small quantity, actually based on fluid dynamic principles. Please, Dr.
Thank you very much. First, I'd like to thank the organizer for inviting me. Then, after 4 sessions of the meetings, nobody can doubt the interventional skills of the Vietnamese intervention cardiologists. And I was not wrong when I introduced the Vietnamese team as the best of the brightest cardiologists of Vietnam. Second one is the English skill, the English proficiency of the team is much better. Here we are at the 4th session, and the English speaking skill of the Vietnamese intervention cardiologists is much better. Now, in my presentation, it is to answer the question. You remember one doctor, I believe, Hồ Thường Dũng, you asked Đinh Đức Huy about the how we are sure that the DCB correctly improves the flow and keeps the flow steady for a long period of time. So my presentation will discuss about that. And I would like to speak in Vietnamese because I don't like it, because beside the faculties, we have other attendants, and I don't like them to misunderstand my hypothesis. Now let's go in some part in Vietnamese. In general, my hypothesis is turbulent flow is bad and laminar flow is good. So how we can have turbulent flow in small arteries? And the second part of my talk is about my hypothesis is everything is caused by turbulent flow due to reverse flow at the lesion at the mid-coronary segment. Can we see it? I will show it at baseline, after PCI, and 30 days after STEMI. I show a case. And another one, if we say that the strong reversal flow is due to severe systolic flow, then it is due to high vascular resistance. And if so, what is distal vascular resistance in the distal extremities? Example for the leg. Because when we talk about vascular resistance, it is in the extremities. So we will see it. We see the reverse flow in the iliac arteries at baseline after PCI and 30 days after STEMI. And the last question is, which medication or factor influence the reverse flow in coronary or peripheral arteries? With this answer, let's say now I have a simple patient. After I did the angioplasty, she wanted to stay longer at home. She didn't want to go back to work. And she asked me, can I go back to work? I have to say yes or no. But I have to prove it. And I have to have the evidence. How we can say clearly that the heart is strongly good, so she should go back to work. Now, you have VIP patients. Let's say now a VIP patient comes to Thống Nhất Hospital after the angioplasty and stenting, and the family say, can he has the same problem again? Can he have chest pain again? How we know that? Now let's see, let's go. Now I speak in Vietnamese. Cái lý thuyết của tôi đó là mình dùng cái engineering để chứng minh về cardiology. Thì trong engineering đó, nếu mà cái flow là laminar thì những cái đường ống này đó, nó không có bị hư. Nhưng nếu mà là turbulent flow thì những cái ống này, cái phía trong cái ống là bị hư đó. Không có, cái đó không tranh thua gì vấn đề về y khoa gì hết. Cái này là hoàn toàn chính xác trong engineering. Thì tôi cũng nói rằng là cái damage in arteries by turbulent flow cũng y như vậy. Nếu mà những cái nó bị những cái chấn thương sang thương ở trong động mạch y như những cái ống nước vậy đó, thì cái turbulent flow xảy ra lúc nào? Đây là cái Reynolds formula, V multiplied by D, hai cái chính, V là speed và D là diameter. Nếu mà cái đường dòng máu chảy nhanh thì nó sẽ có, nó làm cái Reynolds number cao thì lúc kia là turbulent, và D là diameter. Diameter càng lớn càng dễ bị. Thế nếu như vậy thì tại sao một cái động mạch nhỏ là cái diameter là nhỏ, tại sao lại bị turbulence? Và nếu không turbulent thì làm sao mà có thể xảy ra cái damage to the intima? Và nếu làm sao mà không có damage thì làm sao mà có cái atherosclerosis? Thì đây là tôi đưa một cái hình này là nhiều người coi rồi. Đây là một cái, đây rõ ràng đây là một cái right coronary artery, có cái lesion nằm ở giữa. Thì đây là cái hình đầu tiên, A. 0.06 second after. Tất nhiên là một cái phim mình vẫn làm, tất cả các bác sĩ đều làm hết là 15 hình trong 1 second, trong 1 giây. 15 hình, 15 image in 1 second. Thì đây là bắt đầu là diastole, cái dòng máu đi vào đây này, B, mình thấy ở trên cái mũi tên đó. Và cái C là nó đến một chút nữa, đi vô chút nữa. Và D là đến cái chỗ mà bị tắc, bị cái chấn thương, cái lesion. Đây là D. Khi đi nhanh như vậy, tất nhiên là in diastole. Động mạch tim, dòng máu chảy vào trong diastole. Và đi tiếp theo, E. Thì cái dòng máu nó chảy xuống đây. Nhưng mà ở đây nó có cái khung giữa cho cái hình mũi tên màu đỏ đó. Là cái chỗ lúc bây giờ là cái chỗ này là cái chỗ collision between the antegrade and retrograde flow. Cái chỗ hình màu đỏ đó. Và cái hình F, dòng máu vẫn tiến tới, nhưng mà nó vẫn bị turbulent flow ở khung giữa. Và mình thấy là cái mũi tên là dòng máu chảy ngược lại. Mình thấy cái màu đen đó, nó chảy ngược lại. Đấy, G, dòng máu chảy xuống nữa, vẫn thấy cái mũi tên đỏ và cái turbulent vẫn còn nhiều. Và mình nhìn thấy rõ ràng là cái mũi tên đen ở với proximal là cái flow nó vẫn còn bị nhiều ở đó. Và đến là cái H, là đó là cái lý thuyết của tôi là cái chuyện xảy ra cái lesion nằm ở giữa của coronary artery là do cái sự cọ sát, sự collision của cái dòng máu chảy tới và cái dòng máu chảy ngược và tạo ra cái injury to the intima ở cái chỗ đó. Thế thì trong cái về clinical cardiology thì đa số những cái lesion nằm ở cái mid segment of the right coronary artery và proximal LAD, và cái location là bị decided do cái hình số 4 của diastole, là vì diastole là đi vào vòng 4 hình 0.24 millisecond, 0.24 second. Thành ra mình thấy rằng là một cái chuyện này rất là đặc biệt, là cái vị trí của một cái tổn thương nó không tùy thuộc ở cái vị trí, mà nó tùy thuộc ở cái number, cái thời gian đến lúc nào là giao thoa giữa diastole and systole. Và như vậy thì bây giờ câu hỏi là mình đang làm research. Thế bây giờ hỏi là nếu mà như vậy thì cái rupture của cái chỗ mà nó bị tổn thương mà làm ra acute coronary syndrome đó là nó nằm ở chỗ nào? Nằm ở đường vào at the entry shoulder hay nằm ở đường ra exit shoulder of the plaque? Và nó do cái dòng máu chảy tới antegrade hay là máu chảy lui retrograde? Và làm sao để chứng minh như vậy? Thế thì bây giờ đây là hồi nãy là mình coi cái hình right coronary artery mà là lúc bây giờ đó là cái bắt đầu baseline. Bây giờ mình đặt stent rồi thì xem rằng là cái dòng máu nó chảy như thế nào. A là hoàn toàn là full of contrast. B là mình thấy bắt đầu đi vào. Và cái mũi tên màu đỏ là nằm cái chỗ vị trí của cái lesion hồi nãy mà bây giờ mới đặt stent xong, cách đây trong vòng độ 5 phút thôi. Rõ ràng mình thấy cái hình C là cái dòng máu chảy vào rất là nhanh, in diastole. Và D nó chảy ngang qua cái chỗ chấn thương hồi nãy, đi ngang qua cái stent mà không có collision và không có turbulence. Thì điều đó là cái benefit của stenting. Và cái này không cần phải nhìn cái slide của tôi. Khi anh về, các bác sĩ hiện nay là về trong nhà thương của mình xem lại cái slide, cái angiogram của cái bệnh nhân của mình làm. Ngày nào các bác sĩ cũng đều làm stenting hết, thì là thấy rất là rõ. Nhưng mà nhớ rằng là cái này là phải coi chậm, nó nghe coi từng slide một, one by one. Và đây là cái slide E, rõ ràng là cái ở cái mũi tên đỏ đó không có một cái collision nào hết và cái flow vẫn tiến tới. Cái F y như cũ, chỉ khác rằng là nó có một cái gọi là boundary layer màu đen, một cái lớp nó nằm ở bờ đó, boundary layer nó nằm ở chỗ, chỉ khác chừng đó thôi. Và đây là cái cuối cùng, là hai cái slide cuối cùng, đó là thấy rõ ràng là cái dòng máu đi tới và không có cái collision nằm ở giữa. Cái đó là cái đặc điểm của cái stent. Cái đó là cái beneficial effect của cái stent. Đó, thì bây giờ mình thấy rằng là trước khi mà có PCI thì có collision, the turbulent flow at the location of transition from diastole to systole. After PCI, no collision, không thấy collision. Mà có present a thick boundary flow. Cái số 3 là no reverse flow, cái dòng máu không chảy ngược lại nữa. Và cái locational transition from diastole to systole move further downstream. Đây là tất cả những cái gì khi nhìn thấy khi làm một một cái angioplasty hay là stenting. Thế thì câu hỏi hồi nãy hỏi rằng là bây giờ mình làm DCB, mình làm acute MI, mình dùng DCB không mà thôi, thì tôi sẽ hỏi how is the flow? Do we have collision at the lesion site? Do we still have reverse flow? Đó là câu hỏi của tôi. Bây giờ mình đưa ví dụ của cái tiếp theo. Thế thì bây giờ đó cái hôm nay là nói về small artery and tortuous artery, thì cái research tôi đang làm như thế nào? Trong mỗi cái bệnh nhân nó đều có ba cái động mạch hết, L-lady, circumflex and right coronary artery. Thì mỗi bệnh nhân nó đều có người thì có hypertension, diabetes, high cholesterol level, smoking, gender and age. Thế thì nếu bây giờ mình so sánh người này với người kia, thì người thì hút thuốc, người thì không hút thuốc, người thì là hypertension, người là không hypertension. Thế thì làm sao? Thì tôi chỉ so sánh các động mạch với nhau của cùng một người. Trong cái đây là có 3 động mạch, thì mình so sánh tại sao cái lý do tại sao cái bệnh nhân nó lại cái lesion nó lại xảy ra trong động mạch này mà không nhận trong động mạch kia của từng người một. Thì như vậy cả 3 động mạch đều bị giống nhau về hypertension, diabetes, high cholesterol level, smoking, gender and age. Cả 3 người đều bị, từng bệnh nhân đều bị như vậy, không người nào giống nhau. Thì 3 động mạch đều bị ảnh hưởng của những cái risk factor như vậy. Mà tại sao lesion lại, why did a lesion appear only in this location and not at other arteries? Which hydraulic local factor triggers the start of this particular lesion? Đó là câu hỏi làm research. Để ví dụ, đây là một cái bệnh nhân rất là đặc biệt, tôi rất là thích. Cái đặc điểm của bệnh nhân ở bên Mỹ đó là, đây là cái bệnh nhân này là khám vào 2015. Khám xong rồi, làm xong rồi, cứ 3 tháng lại đến khám lại, dù là không có đau gì hết. Cái bệnh nhân này tôi cũng rất là thích, tôi cũng khám lại dù là bệnh nhân rất là hoàn toàn tốt. Là lý do tại sao? Bệnh nhân này đến với acute myocardial infarction, a lot of chest pain. Here's the left system, left circumflex. Here it is a L-lady, some minor lesion, no significant lesion. Severe chest pain. Here is the right coronary arteries, very small. Here we put a wire, after a wire, before the stent, very small. You remember the Reynolds formula, high speed and high diameter. This artery is small. After we put the balloon, here's the arteries. After we put the balloon, so small, 2 millimeter balloon, less than 2 millimeter balloon, and the patient improved. Why a lesion happens in a small arteries and not in a big arteries? Đó là câu hỏi là tại sao xảy ra như vậy? And I follow up the patient every 3 months. And he did very well. I wish I could do an angiogram for him so I can see how the L-lady, how the circumflex, how the right. But he is doing so well. No chest pain, no shortness of breath, active, have no reason to do the angiogram. So now we go to the next one. Here it is, the right coronary artery. The lesion is at a small segment, at the mid area. Why is the lesion happen here and not as a proximal segment, not as a distal segment? Here now we have the left circumflex. The L-lady is normal. The lesion, it is at the obtuse marginal. Here it is. Why a lesion happens at the proximal segment of an obtuse marginal? Why? Now now we look at the flow again. We go here, next one. We see the white color, the blood coming proximally, forward, forward, forward. And now look at the arrow, okay? you see the shape of the artery distal to the lesion. It pointed. Now we see the blood come in and it become less pointed. You see, next one, clearly, you see the flow moving forward. Next one, forward. Next one, reverse. You see the reverse flow. This is the reason why the patient developed lesion in this location. There was a reverse flow when there was collision between the antegrade and retrograde, and this collision damaged the intima and started the atherosclerotic process. Next one, you see? But interestingly, the flow, it retrograde here at the arrow, but also the flow continued to go forward. You look distally. We have more white color here at the obtuse marginal. See? As a tooth, you see? This technique, you can see the flow in both ways. You can do the FFR, but you can measure only one part of the arteries. You see, next one. See, this is the reason why the patient developed the lesion. So, in my theory, is we have reverse flow, we have collision with turbulent flow at the location of transition from diastole to systole. Now, you remember with stenting, we delete, we stop the reverse flow, and we don't have any more collision with the stenting. Now, let's go back to the next one now here. So, let's see here, we have the result PCI, a large small vessel based on hydraulic, in case number 3. Okay, that's an interesting case. Here it is, a patient come with acute MI. You see the right coronary artery was totally occluded distally. And here it is after they put a stent in the right coronary artery. And here it is the LAD. The LAD has a lesion at the mid-segment and a lesion at the proximal segment of the diagonal. So this is the same day of acute MI. Now, this slide, this angiogram is very interesting. You will see. Okay, so at the proximal, at the left main, you see the blood coming in. And you see because of the reperfusion injury, we see the contrast in the myocardium. And you can see clearly when it is diastole and when it is systole, with the left ventricle expanding or contracting. Look at this, look at the arrow. Look at the arrow first. See, dilating, but remember, it is 15 frames per second. It is 0.06 seconds per image. You see? Stop. Expanding. Smaller. This is contracting now. You see, in systole now. In systole, wow. You see? The left ventricle contracting. It is all in your angiogram. You do it every day. Many of them, just not one. And you see that, you see everybody, we didn't know. You see? Now, here, in this one, you can say clearly when it is systole, when it is diastole. Now, then you look now at that time, now at this moment, you look at the picture of the blood going into the, went into the left main. Okay, so one, you see, the blood going in diastole, fast. But now, the blood going to at the proximal LAD now. Okay, it begin to stop at the lesion. In systole, the blood continue to go in, but more slowly. And it has some reverse flow. I say some. Okay. Okay. So now let me go. This is the day of acute MI. It is March the 4th. And 3 days later, I did the angioplasty of the patient. So here it is. We just stented the proximal LAD, and we just ballooned the proximal diagonal. Now we look at again two things. You see the myocardium still filled with some contrast for us to recognize when it is systole and when it is diastole. Look at this one. See? Diastole, systole. You see that? And so we can time the entry, the flow into the coronary artery in diastole and systole. This is the first time in medical history you can see that. Okay, let's go. Okay, here, systole, you see it go in but slow. Now, you see now with the diastole. See? The flow going quicker. And you see the flow, the blood coming at the mid segment of the diagonal, of the LAD. No reverse flow, or a little bit. You see, in this paper, in this slide, purposely, you look at the left lower corner. Nhìn vào cái góc của cái phía dưới của cái góc trái dưới đó. We have the number of the slide, of the image in the coronary arteries. You see now we have số là 38, 39, 40, 41, 42, 43, 44 to show the sequence of the, you see this one in your angiogram every day. But clearly, you see, you don't have reverse flow here. Clearly. You see? Now, so after collision with stenting, we have no collision with turbulent flow, no reverse flow. Okay. Now, so this patient, 3 weeks later, she came back to the hospital with chest pain. Sure, I like it because I have the reason to do the angiogram. I want to see the flow. Now, you see how beautiful the balloon angioplasty of the proximal circumflex, proximal diagonal. It looks so easy and beautiful. Okay, now we go back again, and 3 weeks after, we don't see the lighting up of the contrast in the myocardium. We don't see it anymore. The patient recover from reperfusion injury. We heard about reperfusion injury, but I am sure you never saw one. Now you see it. You see, in the last one, you see the lining up of the left ventricle. Okay, but look at this one. No more staining of the myocardium. You see, 3 weeks after angioplasty for stenting, for acute MI. And now we look at we go slow now. And if you want to check, you look at the number of the left lower corner. We're sure that the slide, the picture came in one by one. And now look at the coronary artery. Okay, here. Okay, so we are the left main, the blood came in. Okay, so 1, 2, 3, 4. Usually 4 is the end of diastole. Now systole. 5, 6, 7, 8, 9, 10. It's slow, but no strong staining of contrast or mixture of contrast and blood. The sign of turbulence. No turbulence because it's a stent there. Look at the left second left, the diagonal. So beautiful. No more reverse flow. You see? Now I send this set of slides to Vietnam. If you want the exact slide, you ask the team to send it to you, and you look at by yourself on your laptop. You see? This is how we can say. So after I did this case, and she asked me, can I go back to work? Can I stay 1 more month at home? I said, yes, you can stay 1 more month at home. But if you want to go back to work, I say yes to, because everything is doing better. You see? So look at it again. You see, in this slide, in this angiogram, no reverse flow, no turbulence, no delay of the flow, and no contrast staining. The patient recovered totally from reperfusion injury. Okay, so let's say now Dr. Jung, he asked before, how do we know that if we use DCB on a patient with acute MI, how we know that the patient improved? So the question I asked is, what is the flow after DCB? I want to be sure no reverse flow and no myocardial stain. You see? So if you have a VIP coming to the hospital and the family say, are you sure he's recovering well? You say yes, because he had no more reverse flow and no myocardial stain. See? Now, we just say that. We look at the coronary artery, but are we sure? How is the distal vascular resistance? How do we know that? Not that. This is why I told Dr. Lee and Dr. Faisal Latif, if after your lecture you can leave. They are happy. This is a secret. I have to publish first before we can tell to everybody, you know. So here it is. We thought that the reverse flow was due to severe distal vasoconstriction from systolic pressure. So if so, how is the vasoconstriction in the distal arteries in the legs, in the foot, in the feet? How is the reverse flow in the iliac artery? Okay, here we do same thing. We do 3. One at the day of acute MI, March 4th, March 7th, and March 30th. Here's the iliac artery. And you look. See down. Remember, the strong flow in peripheral arteries is in systole, not diastole. So the 2 strong flow going down is at the beginning of systole. And now you see the reverse flow. And you look at the syringe of contrast. It stands still. We did not inject. You see that? Okay. You see how the flow goes now. Systole again. Going fast, and you see the reverse flow. I didn't touch it. You see, this is on the day of STEMI. Okay. Okay. Now, on the day of STEMI, you know that it is March 4th at at midnight, 0:25, 12:25 a.m. This is the way how we say that. And here's the blood pressure. 150/75, the heart rate a little bit up. Because a little bit up, I gave the patient low pressure. Look at 0:48, I gave the patient low pressure to bring down the blood pressure and to bring down the heart rate. So you see that in the day of admission with acute MI, the patient had prominent and prolonged reverse flow in the iliac artery. Now, 3 days later, March 7, we have the same. Here's the iliac artery going down, still have come up, reverse flow, but not as strong as the first day. Going down, up, okay? So here's the blood pressure during the procedure at 10 a.m., I believe on a Monday. Heart rate is good, blood pressure well controlled, no diastolic hypertension. You see? Now, so we have less prominent and shorter reverse flow. And what medication did we give him? Her. Atorvastatin, metoprolol, Brilinta, Farxiga, and glucophage. See? Now, March 30th, 26 days after STEMI, she came to the hospital. She said, I had chest pain. We cannot do stress tests. We had to do an angiogram. Okay, so here you saw the angiogram, the coronary arteries look good. No reverse flow, no collision, and no staining in the myocardium. How about the iliac artery? Look at this one. Same thing. Now, you see I inject. Look at the syringe. You inject in, inject, stop now, okay? The flow coming down. Do you see the reverse flow? Very little, minimal. We fix the coronary arteries, but also we fix the high vascular resistance in the peripheries. This is a second concept. See, now here's the blood pressure at that time at 2 p.m. We have good heart rate, good blood pressure, and so no or minimal reverse flow. So let's say now at the end. So I told the patient, everything is good. If you want to stay long at home, I can do it. I can write a paper for you, and you stay 10 more days, 20 days for fun at home with salaries. But if you say, I want to go back to work, I say, yes, you can go back to work. But can you develop chest pain again? Can your artery close it again? If you take medication every day, no closure. So we have so strong evidence of the good result. And this is important. This is important because, like again, let's say you have a VIP coming to your hospital and have an angioplasty. And the family say, yes, you can say, yes, he's doing good. And if now another doctor, your teacher, another cardiologist call you and say, are you sure the patient is doing good? Can he go home? Can he go back to work? And then you will look. You look at the angiogram after angioplasty. Does he have reverse flow? Does he have collision in the lesion area? How the flow in the leg, in the iliac artery? Does he still have reverse flow? If we control it, we have no collision, no reverse flow in the coronary arteries, and no reverse flow in the iliac artery. You say, yes, he's doing good. If he controls the diabetes, if he controls well the high cholesterol level, if he stops smoking, if he exercise, if he take medication every day, aspirin or Plavix or statin, that everything's so clear. We have the evidence of the strong and good reversal problem in the coronary arteries, then we are okay. And so conclusion, before PCI, the culprit mechanism is the collision with turbulent flow at the location of transition from diastole to systole. But after PCI, you make a miracle. No collision, no reverse flow in the coronary arteries and in the iliac arteries. Thank you very much.
Thank you very much, Professor Thach Nguyen, for the very helpful theoretical and basic presentation. I think it's informative for even the young cardiologists, interventionists, and maybe to the senior. I have two comments with your presentation. The first is the turbulence at the plaque. On the image that we can have is after the plaque is formed with the turbulence. I think the recurrent flow is the result for between the lamina and the turbulence after the plaque. And the beneficial effect of the stent is proven is after stenting, there is no or minimal recover flow. So this the short, the long effective of the stenting. But how about the initial time? I mean, the primary time when the plaque is just the first time of being formed. There is no plaque, and why the plaque happened to that location. And the second question is the DEB. I think the DEB has the same result as the DS or stenting if the preparation before deliver the drugs is good. I mean, less than 50% of residual stenosis or less than that. So if the plaque is minimal, I think the long result is the same as DS.
I would like to, I agree for the second question. No question about that. I mean, I asked that we have to have correction of the flow with no collision, no turbulent flow after stenting or after DCB. You see, I talk about the first question now, and the first question it is, I will speak in Vietnamese so many other people can understand. Câu hỏi của giáo sư Nguyễn Cửu Lợi là nếu mà bây giờ đó mình có một cái lesion ở cái giữa của cái coronary artery RCA hay LAD đó, thì đó là cái giáo sư lại còn nhắc tới là có thể là do cái lesion, cái turbulence nó có thể tự nó do cái lesion đó. Thế thì bây giờ ngay bắt đầu thì sao? Thì tôi cũng đang làm một cái research như vậy, thì tôi có một cái, thì tôi rất là thích làm những ca nào mà lại normal. Ví dụ bây giờ mình khám bên mình đoán là normal đó, thì bây giờ mình làm cái angiogram thì mình coi rằng là nếu mà người này bị normal, tất nhiên normal tất nhiên là họ có một cái vài cái lesion nhỏ đó, ví dụ như 5% thôi, tức là bắt đầu đó, thì cái người bệnh nhân đó họ có cái collision hay không. Thì thực sự tôi có làm một khá chắc độ khoảng độ 5-3 ca gì đó, thì họ lại không có. Cái đó mình đang coi lại. Thì cái chuyện đó nó mới hỏi là tại sao nó không có. Thì mình phải coi rằng là cái bệnh nhân đó, cái huyết áp nó có control hay không, và cái tuổi nó như thế nào. Là tại vì cái người bệnh nhân mà từ khi mà Thì hỏi là tại sao cái thí dụ cái đứa con nít nó không bị, là tại vì cái dimension nó nhỏ đó, cái diameter nó nhỏ đó, thì cái diameter nó phải lớn lên trên 2 cơ. Tất nhiên là bắt đầu cái tuổi thanh niên á, thì lúc mới bắt đầu có lesion. Thế thì bây giờ nếu mà bây giờ cái tuổi thanh niên á, mà không có huyết áp cao đó, thì không có bị reverse flow, không có bị high vascular resistance. Thì nếu mà không có high vascular resistance thì không có bị cái reverse flow. Nếu không có reverse flow thì không có collision. Thì thường đa số là người bệnh người ta bị vào cái tuổi trung niên. Thì cái tuổi trung niên á, thì là cái lúc bây giờ là bắt đầu có huyết áp cao, và lúc bây giờ cái cholesterol nó mới cao. Thế thì phải cái sang thương đầu tiên, cái injury đầu tiên là do huyết áp. Và nếu bây giờ hỏi bệnh nhân này mà không có huyết áp cao, bệnh nhân chỉ có huyết áp cao không mà thôi, mà không có high cholesterol, thì họ có tạo ra cái lesion không? Làm sao có lesion được? Và tại vì bây giờ cholesterol nó không cao, thì thành ra vì vậy cái bệnh nhân này họ chỉ bị injury và calcification of the lesion without stenosis. Có thiếu gì bệnh nhân mà bị calcification mà không có lesion? Tôi thấy đầy rồi. Thế thành ra vì vậy mà tôi đang làm cái nghiên cứu đó, thì cái nó hơi khó một chút, là vì nó lâu dài, kéo dài quá. Thí dụ một người 50 tuổi bên Mỹ, 50 tuổi họ mới bắt đầu bị bệnh. Hay là người đàn bà là phải sau mãn kinh 4 năm mới bắt đầu có bệnh. Thì lúc bây giờ đó mình thấy rằng là trừ trường hợp mà bị hypertension thì người ta có thể có cái collision, là vì nó bị high vascular resistance, thì người ta high systolic pressure, thì khi mà người ta khi đi vào là đi diastolic, khi đi ngược lại là đi systolic. Và nếu pressure của systolic mà cao thì nó sẽ dễ làm ra cái reverse flow. Thực sự ra thì nói là như vậy, thì tôi đã thử 2 ca, tôi coi hai cái bệnh nhân mà có huyết áp là trên 200 hết, mình làm angiography mà huyết áp trên 200 là nurse đòi là phải hạ huyết áp xuống, để mà tại vì khi mà puncture thì sợ nó bị chảy máu nhiều quá, mà tôi không chịu. Tôi cứ làm angiography mà huyết áp trên 200 để xem rằng là cái người đó họ có reverse flow hay không. Thì khi mà làm research thì phải nói thật, chưa thấy. Tôi làm 2 ca rồi, coi lại, làm y như mọi người bình thường, thì mình coi rằng là cái người mà huyết áp trên 200 thì xảy ra như thế nào, thì tôi chưa thấy. Thành ra vì vậy câu hỏi của giáo sư Như Lợi đó là trả lời chưa được, cái là vẫn trong gọi là trong vòng nghiên cứu. Xin cảm ơn.
Xin cảm ơn thật. Any comment, any question from the panelists, please?
I have some comment. Thank you very much for very excellent presentation of Dr. Thạch Nguyễn with a very new theory, a new concept in the coronary artery disease. As you know, for the long time we think the pathology or the mechanism of the coronary artery disease is due to the atherosclerosis plaque. And we often, in the treatment, we use a statin to stabilize the plaque, but the atherosclerosis theory not influence everything in the coronary artery disease, because we have the common site, a common location in the artery to form the plaque, such as in the area bifurcation, or such as in the pop of the carotid artery, in the bifurcation where the blood flow is often met disorder. And I think the theory of fluid dynamic, not only in the theory of Dr. Thạch Nguyễn. By now we have the vascular sonography, and vascular sonography have the same theory. They have the laminar, they have the turbulent flow, and the laminar flow in the normal artery, and in the artery with the atherosclerosis plaque, the blood flow become the turbulent. When the go through a block, a stenotic block, or some position in the bifurcation. And by now we have a one application, the turbulent flow in coronary artery disease in the stent. This explanation for stent thrombosis. As you know, we have many factors to affect to the stent thrombosis, but the one factor of stent is the strut, thin strut and thick strut. And they say if the stent with thick strut, the blood flow when go through the strut, it makes the microturbulent after strut. And microturbulent can make detached endothelium cell. And endothelium cell detached, it means it induces the thrombosis formation. So I think the dynamic, fluid dynamic can explain many things. And because the coronary artery disease, coronary artery is located inside the thoracic, and the vascular sonography cannot do examination. But if outside, such as the peripheral artery disease, we can examine laminar turbulent flow in the ultrasound very clear. If laminar turbulent, the color is one color, look like a blue, red. If the turbulent is aliasing color, it means blue and red mixture, and it makes aliasing color, so on, and many things. So I think Dr. Thạch Nguyễn, if some of the young doctor in your team, you can send them to learn vascular sonography. They can learn something from ultrasound sonography. So I think, but by now, application, the theory of the Dr. Thạch Nguyễn to daily practice obscure not very much, because we in the way to build the theory and in the way to prove for the value of dynamic of fluid dynamic in coronary artery disease. I think so. Thank you.
Professor Thạch Nguyễn, very excellent presentation. I love your theory, but I have the question for you. That I read a book about the physiology by Arthur Bruce, Burn and Levy Physiology, 6th edition, 2010. They say that the flow to the RCA mainly in systolic phase, and on the left side is different, usually on diastolic phase. So what do you think about this? And because your study is about the analyze the picture frame by frame, so how do you differentiate between the diastolic or systolic phase of injection compared with the normal or the original flow of the coronary artery? Thank you.
So I will thank you very much. Thank you for the comment of Dr. Hồ Thường Dũng, and I really appreciate that. And let me answer in Vietnamese. Tôi thì cảm ơn thầy Dũng đó là đã cho lời comment. Thì hiện nay cái vấn đề nó đang là gọi là investigational, và cái bắt đầu với 2 năm nay vì Covid tôi không đi Việt Nam, thành ra còn giờ để làm research và viết bài. Thì năm nay sẽ đăng rất là nhiều bài báo, và cái cuối tháng 5 là lần đầu tiên sẽ báo cáo cái lý thuyết này ở một cái hội nghị ở dưới Florida. Họ cho 1 giờ đồng hồ để mình đứng nói. Thế thì cái chuyện nó cũng rất là thích. Thì nếu mà có thể được nữa thì vào tháng 7 thì tôi sẽ đi Boston, đi học ở Boston. Lúc bây giờ tôi sẽ tới cái chỗ gọi là Harvard Clinical Research Institute của ông Michael Gibson để trình bày cái lý thuyết này, thấy không? Tại vì mình phải trình bày để người ta hỏi ngược lại giống như hồi nãy đó, thì là nó thì cái đó là cái chuyện đi làm research thì mình phải đưa ra cái ý kiến và xong đó mình nghe những cái lời phản hồi của các bác sĩ trẻ hay là các nghiên cứu thì sao, thì chuyện nó bình thường lắm. Bây giờ đó bác sĩ Ngô Minh Hùng có hỏi câu hỏi đó thì tôi nói thế này nè, trong cái hai cái cách mà làm hiện nay đó, cái vấn đề mà làm cái flow mà đi vô trong systole và diastole là dùng đều bằng phương pháp là Doppler study, mà cái đó là không có chính xác, là tại vì khi mình đo Doppler mình chỉ đo được một chỗ thôi chứ mình không đo được hai chỗ. Doppler study, và cái Doppler study là cái đo mà gọi là indirect, not direct. Thì hồi nãy trong cái hình mà có một cái slide mà hồi nãy tôi cũng đưa ra đó, thì có rõ ràng là cái hình mà của người acute MI mà cái ngày 7 tháng 3 đó, tức là 3 ngày sau khi mà người ta bị acute MI đó, thì rất là ngày MI là ngày 4 tháng 3. Cái hình rất là rõ là cái hình đó là cái hình của cái người đó, cái quả tim nó đập ra đập vào, rõ ràng là diastole systole. Mình là bác sĩ về tim mạch mình nhìn thấy biết liền. Giờ tôi xem lại, let me see. Tôi sẽ làm lại, tôi sẽ coi lại. Bây giờ lấy share screen đó, thấy không? Share screen đó thì bây giờ đó đấy, thì rõ ràng là bây giờ hỏi rằng là các bác sĩ tim mạch nhìn cái hình này, mình nhìn rõ ràng là đây là diastole và systole liền. Cái rõ ràng là cái quả tim nó đang đập, đây là systole, thấy không? Và cái hình này chưa có bao giờ công bố trên lịch sử thế giới đó. Cái hình này sẽ công bố tại Florida. Rõ ràng là cái này bây giờ hỏi rằng đó, bây giờ là diastole, thấy không? Rõ ràng. Sorry, đi ngược lại. Đây. Diastole này, động mạch nó đang giãn ra này, tục quả tim đang giãn ra. Systole là đang giãn vô này. Và trong lúc đó mình có cái coronary arteries nó đi vào, cái dòng máu đi vào. Chính cái này là giải thích được dòng máu đi vào trong diastole hay systole lần đầu tiên trong lịch sử y khoa. Chưa bao giờ xảy ra hết, chưa bao giờ thấy hết. Thì rất là rõ ràng cái đó. Thế thành ra vì vậy hồi nãy tôi làm cái này đó thì tôi có bỏ mấy mũi tên để cho mọi người nhìn thấy được. Tôi nói rồi là các bác sĩ nhìn cái hình này every day like you, because you do more cases than in the US, and you can do 3, 4, 5, 6, 7 a day. We do 3, 4, or 2, or 1. You see? So, but nobody pay attention about the staining on the myocardium. And here clearly we see that the diastole and systole. I have another case, much clearer, when the patient had right ventricular infarction. We see the lining, the staining of the myocardium is so clear and so loud, so clear to see that it is systole and diastole. Then from here you can see clearly how the flow into the left main. Is it in diastole and systole? Never before in medical history. We see clearly that, no question. You see? So in this patient, we have to see, and also look at the. I show the picture of the leg now. You see the leg, the systole. I have the picture of the aortic root. We see clearly systole how the flow goes. Very clear. You see? So, and again, I love to show my picture, but I say, you go back to your hospital, you go back to your cath lab, you look at the picture, you see it. Because if we don't look for it, we don't see it.
May I have a comment? I think most of the DSA system now is incorporated with an EKG. And can we base on the EKG, the phase of EKG, to say that it's systolic or diastolic? Is that?
Yes, this is when you do the echo. Let's say when you want to look at the tamponade. And so you look at the EKG, and you have at the beginning of the QS complex, it is systole, and at the T wave, it is diastole. And you time it, and you see how the wall of the right atrium, is it collapse right ventricle? Is it collapse of the right ventricle free wall in diastole? This is the definition of tamponade. You see? So how do you time it? You use the EKG. This is my my reply to the question of Dr. Hồ Minh Hùng and Nguyễn Cửu Lai.
Yeah, thank you very much, Professor. Cái này em xin phản biện thôi để thầy.
Thank you.
Thầy đọc cái cuốn sinh lý của bên họ ghi vậy thì em cũng gọi là mình có cái nhìn thôi, là cái mạch vành phải nhận máu chính từ thùy tâm thu, trong khi đó mạch vành trái nhận máu chính từ thùy tâm trương. Thành ra chỉ nói tiếng Việt để trình bày với thầy thôi, là như vậy thì nó có interfere với lại cái cách phân tích của thầy hay không.
Cái hội nghị mà mình báo cáo vào cái phương pháp này là hội nghị về physiology đó ở Florida, cuối tháng 5, thấy không? Thế thì bây giờ các người mà viết về physiology có cái yếu đó, họ làm trên animals, họ làm trên research, họ không phải là bác sĩ về clinical. Thành ra vì vậy đó, cái chuyện mà những cái hình này đó là những cái hình mà mình đang chiếu lên đó là rõ ràng là nhìn cái frame đó là biết là chỗ nào là systole, chỗ nào diastole liền.
Thank you, Professor Thật Nguyễn. Now your section is time is over, so we invite Professor Hồ Thư Dũng for closing remark.
Okay, thank you, Dr. Nguyễn Cửu Lai. It is the time for us to wrap up our meeting. I think today the meeting is very interesting. Myself, I think I can learn many things, and the topic today is very, very challenging and very interesting. A small vessel and long diffuse lesion, and very tortuous lesion. When the interventional cardiologist do the PCI, the small vessel and long diffuse lesion met for the procedure more difficult. When you do ballooning pre-dilatation, it's very easy to dissect, to rupture, and we need the long stand. And sometimes it prevent to delivery stand to the lesion. And the tortuous lesion is the same situation. Sometimes it made more difficult, and the small vessel long diffuse lesion and the tortuous lesion it belong to the chip. Chip is mean we do the intervention in the high risk and the complex lesion. High risk it means the elderly lesion, renal failure or heart failure, someone, and the complex lesion look like CTO, left main bifurcation, very calcified, small vessel along the lesion. And we can hear, we can see some case report from my presentation to show we can hear the many tip and trick from the effort. And the tip and trick, we made easy to understand the last purpose is to deliver stand to the culprit lesion, and we should map how to increase the support for the intervention. It means backup the guided catheter. We should use guide extension catheter, and we should pay attention to balloon to inflammation, and we have one more method for the treatment. It means drug-coated balloon. Sometimes we can choose the strategy, new strategy, a stainless strategy. It means no stent strategy. It has some indication. And the important thing when the young interventionist, you do the intervention to the small vessel and tortuous lesion, you should pay attention to the hemodynamics. It means we should predict to acute ischemic crisis. And we should have the learning curve. It means when the young interventionist, because by now, the elderly patient more and more account for the majority of the case in the cath lab. And in the patient with elderly patient, we often see long diffuse lesion, a small diffuse lesion, and very calcified lesion. And when we do the PCI to these type of the lesion, we should, the first you should recognize, and the second you should predict the complication or obstacle happen during PCI, and you should have an ability to manage that. So I think we can learn a lot of things from the debate, from the opinion, from the comment of the expert power of America and Vietnam. And one more again, thank you so much for the panelists, for the speaker, to prepare the very excellent presentation for us to discuss, for us to analyze, for us to comment something. And once more again, thank you so much to Dr. Thạch Nguyễn and your team, the American team, with the very excellent effort to give us many opinion, many tips and tricks to the many difficult reasons. And for the last word, to say goodbye to everybody. Thank you so much, and good night, Dr. Thạch Nguyễn, and have a good appetite for the doctor in Vietnam. Thank you so much.